ग्रीन जी
पर तो वीडियो हो गया नहीं पॉज होगी वीडियो पॉज हो जाएगी जेडी बन रही
अच्छा तो फिर ये
कोई नहीं पॉज हो जाएगा
चल वो यार मुझे फोन आने नहीं
कुछ नहीं आना
देखो ना
कोई नहीं मैं बना लेंगी
पी सकते हैं
Good evening, sir.
Good evening. All set.
All set.
बोलना तुसी
Hello, Dr. Sidhu. How are you?
I'm fine, sir.
Nice to see you.
Fine. Thank you. Same to from my side. Very nice seeing you too.
Manjeet Singh ji.
Sir. How are you, sir?
That's fine. Good evening.
Good evening.
Hi, Dr. Manjeet. Jaideep here.
Hi, sir. Nice seeing you. We hope to have a very good session today.
Sir, shall we start, sir? We are live now, sir.
Yes, we can surely start.
Yes, sir. So, very good evening, all respected faculties and delegates present over here. On behalf of Corona Remedies Private Limited, I, Vasisth Mehta, welcome you all for the COR Connect live webinar organized by Punjab OBGY societies. So, let us start our academic tour with lightning of the lamp. Now, I would like to invite our coordinator for today's event, Dr. Mini Bedi ma'am. Ma'am is Associate Professor in Department of OBGY, Adesh Institute of Medical Science and Research, Batinda. She is Fellow and ex-Registrar of Fetal Medicine Unit, Hyderabad. She has done fellowship in minimal access surgery at Delhi, and she has special interest in high-risk pregnancy and fetal medicine. So welcome, ma'am, and over to you, ma'am.
Thank you so much, Mr. Vasisht.
evening लेनी है शाम को 4-5 बजे
With all your permission, I'm really not able to express it in words how happy I'm feeling today being the coordinator of this show and sharing the dais with such great people around. Well, to start with, I would like to introduce our chief guest, Dr. Iqbal Singh Ahuja. We already know him very well. He's the director of Iqbal Nursing Home and Hospital, Ludhiana. With 54 years of dedicated service to the medical field, we know him as somebody who got IVF to Northern India. First test tube baby of Northern India was born in 1992 at Iqbal Nursing Home. Well, he has been the founder secretary of Indian Menopause Society, Ludhiana, and has contributed to many scientific and non-scientific articles as well. The author of short stories we know as Middles in the National Diary, the Tribune. He is a life member of so many societies in India. As a alumni of CMC Ludhiana, he is working now as a senior consultant at Iqbal Nursing Home Hospital, Ludhiana. Sir, I welcome you to be here at this dais.
Thank you very much.
I would like to introduce the guests of honor today. Dr. Parneet Kaur. Vashisht, can I see the screen, please? Yes. Dr. Parneet Kaur, she's the professor and head the Department of Obs and Gynae, Government Medical College, Patiala. Sorry, okay. Well, with a teaching experience of more than 17 years, she has been an examiner for the undergraduates as well as the postgraduates for the last 10 years, with 45 publications in the national and international journals, being reviewer to very good to reputed specialty journals. She is the president of Nabha Obs and Gynae Society, with special interests in high-risk pregnancy and contraception. Sorry. I would like to welcome you, ma'am, on behalf of the Punjab and Obs and Gynae Society to this webinar. The second guest of honor today in this chair would be Dr. Gitanjali. Dr. Gitanjali Kaur. She's the director and consultant PAL Hospitals, Ludhiana, with 24 years of experience in the clinical field. She's the senior vice president, Ludhiana Obs and Gynae Society. She has been the speaker and chairperson at various local and national level conferences, with special interest in high-risk OBS and ultrasound, laparoscopy, surgery, and infertility. I welcome you, ma'am, on the behalf of each one of us present over here.
Yeah, good evening. Yeah, thanks for the warm welcome. I have logged on from Dr. Vidhu's phone because we were both sitting together and preparing for the Yuva Foxy, upcoming Yuva Foxy. And we're looking forward to meeting you all for the Yuva Foxy. And
of course, ma'am, we are also eagerly waiting for Yuva Foxy, ma'am.
Looking forward, yeah.
Well, I would like to request Dr. Iqbal Singh to say a few words, sir.
Thank you very much, Dr. Mini. Mini is my daughter's name also. Dr. Mini.
I'm so glad, sir.
Gitanjali just said, they are going to have Yuva Foxy, but I have got hundreds of invitations for Yuva Foxy. I don't know whether they are including in Yuva or not, but they are sending a lot of invitations.
We are, they have named it.
Member, sir.
But madam has named it as Foxy with Yuva, so everybody is going to be involved with it.
Sir, आपके बिना कोई Foxy Yuva Foxy नहीं चल सकती ना, वो भी लुधियाना में.
I'm very happy. I become much younger now.
ये युवा के साथ तो we are made, हम सब young feel करते हैं सर सबके साथ, तभी तो young के साथ करेंगे तो we'll also feel younger only.
It's my privilege to be chief guest today, and especially with two beautiful guests of honor, one from Princely State, Dr. Parneet Kaur and Gitanjali. I call her Dynamite. She's a dynamite of knowledge, And she speaks, just covers everything so nicely. And I always thought that I was very intelligent and a very bright student. But when I say these girls, I feel I was wrong. I was never so intelligent, But maybe the definition has changed, In our time, the definition of intelligence was much different. I don't know what it was, but we were called intelligent. But now I realize we were not.
You have been very humble to say that, sir.
Yeah. So, and the way of teaching, way of learning is a continuous process. Even after spending 54 years in my job, I still learn. Sometimes I learn from my assistants. They will say, sir, isko aise kar do. When you are doing something, this essay, so it pays you to listen to them. And if you say, tumhe kya pata hai, like this, egoistic, then you stop learning. So I think one must keep eyes and ears open, and then you will see everything you learn. Learning never stops. I was just reading that even fetus in womb is also learning. And I think fetus in learning, we also learn till death. That time we realize that we didn't do this. So that means the learning is a very continuous process. And today is a very lucky day. I'm learning more. And speakers are very, very intelligent. Dr. Patel is there. Dr. Tank is there. I will see Parneet Kaur and others. I can mention whole name, but I think it's a very nice team. So I'll also become wiser. Thank you very much for giving me a chance to listen to this. Thank you.
Truly said, sir. Thank you so much for your beautiful words, sir. I would request Dr. Parneet Kaur to say a few words, ma'am.
Good evening, everybody. Thank you, Dr. Mini, for that kind introduction. It's really an honor to be part of this academic event. My respects to Dr. Iqbal Ahuja, a very senior academician and always an asset in any of the webinars. We have very important topics lined up for today. They are fetal growth restriction, latest on MTP Act, and critical care in obstetrics, with reputed and experienced speakers and chairpersons from all over India. I thank the organizers for inviting me, and I wish the webinar is a great success. And I assure the delegates that it will be definitely enriching their experience and help them in day-to-day practice. Thank you very much. Thank you indeed.
Thank you so much for the wishes, ma'am. I would like to request Dr. Gitanjali now, kindly for a few words, ma'am.
Thank you, Dr. Mini. We all know that intrapartum or antepartum stillbirth is a very big chunk of our, we see it in everyday practice, and so many times we do not have any reason to ascertain there. And FGR forms a very important, I would say, bulk of the iceberg, where FGR cases can very well result in intrapartum or undiagnosed FGR, khaskar, especially the late FGR, which sometimes is not picked up, and that is one of the reasons for stillbirth. So, and we got a very sorry figure as obstetrician when a stillbirth occurs. It's not only a mental strain for doctor, patients, we just cannot describe their bereavement, but for us also it's a lot of strain. It takes us a month or so to get out of it. We are so scared to touch the next patient. So yes, FGR recognizing is a very important part of our day-to-day practice, and it is a very relevant, clinically relevant topic. So I'm happy that Corona has taken up this job of putting this knowledge sharing on a platform, on a webinar platform. And we hope all of us gain a lot from this webinar. And I wish you all the success and best of luck.
Thank you so much, ma'am. Well, now let us start, with all your permission, let us start our first session, which is on fetal growth restriction. And to say about this, we will have none other than Dr. Chinmay Ratha, who would, I think, be the best person to say about this. We will have Dr. Sujata Sharma and Dr. G.K. Bedi in our as our chairpersons. We all know Dr. Sujata Sharma. She's our own Dr. Sujata Sharma. She's a senior consultant, Obs and Gynae, Apollo Hospitals Private Limited. She's the immediate past president of Amritsar Obs and Gynae Society. She has acted as a past HOD for Obs and Gynae Department, Government Medical College, Amritsar, and the past director of medical education and research. She has been the past principal for Government Medical College, Amritsar, and a life member of so many other societies, including FOXY. She's the organizing chairperson for North Zone Yuva FOXY 2013. And she has delivered over about 150 guest lectures with so many papers and publications. We welcome you, ma'am. The other person in the chair would be Dr. G.K. Bedi. She's the director of Bedi Hospitals. Bedi Hospital. She has graduated from Madras Medical College, Chennai, and then after that went to Lady Hardinge Medical College, Delhi. She has took her training in infertility specifically from Apollo Hospitals, Chennai, and worked with Dr. Pandyan, and from Kolkata under Dr. B.N. Chakrabarti. We all very well know that. She has been trained in ultrasound under Dr. S. Suresh at Mediscan, Chennai, and she's the founder president of ISAR Chandigarh chapter. She's running Bedi IVF since past 20 years. We welcome you, ma'am. With the permission of the chairpersons, we would like to start the first session. Ma'am, if you could please introduce Dr. Chinmay Ratha for the first session of fetal growth restriction. Sujata ma'am. Dr. Sujata ma'am, are you here?
I did not unmute and started speaking. Sorry. Okay. So we have the first speaker of today's session, Dr. Chinmay Ratha. Dr. Chinmay is the Director Resolution Fetal Medicine Center, Navodaya Hospital, and Senior Consultant Fetal Medicine and OBGY Yashoda Hospitals, Sikandrabad. She is also a Fetal Medicine Foundation approved trainer in India, RCOG moderator for ARP MRCOG2 exam, ICOG Foxy certificate course, center head for fetal medicine, and Anne Donald USD courses. She is the center director for these. She's widely decorated, has so many awards and publications to her credit, especially the Dr. Rajat Ray Fetal Medicine Award, Foxy 2019, Foxy Young Author Award, CS Dawn Gold Medal for Best Research Paper, and she has held so many posts in the past, and the latest being she is the chairperson-elect Foxy Perinatology Committee for the year 2020-23. Dr. Chinmay would be speaking on a very, very important topic, as Dr. Gitanjali has also emphasized. FGR is a very, very important clinical condition which we need to be very vigilant about and needs to be identified as early as possible during the course of pregnancy so that we can modify the course of pregnancy and the route and the time of delivery of the fetus. So ultimately the mother and the baby both are happy and well after the delivery. So here I introduce and here I present Dr. Chinmay Ratha for the first session of this CME webinar on FGR, fetal growth restriction. Over to you, Dr. Ratha.
Thank you. Thank you so much, Sujata Madam. Indeed, it's a great privilege for me to be here amidst such luminaries today, this evening. And Punjab is very close to my heart. My husband, being an army officer, was posted there several times in Batinda and Gurdaspur. So I'm very happy to be with all of you. Now, thank you for this beautiful topic on intrauterine growth restriction, which is a very old problem, but the new concepts have kept coming up in this, and although it remains a clinical challenge for most of the clinicians, we know that there is a method of handling things better in IOGR if we keep ourselves updated. This is a beautiful quote I would like to start with, which says that life is growth. If we stop growing, technically and spiritually, we are as good as dead. And that's exactly what happens to the fetus if it stops growing inside. So we know that fetal growth or growth in general is a sign of life, and it is something which just goes on every single day. We grow some way or the other. And in the fetal life, from a single cell to the fully formed fetus, which comes out as a newborn, there is a continuous growth happening on a daily basis in utero. And this growth is regulated by a genetically predetermined potential. So every baby has a potential to grow. Sorry, can you hear me? Yeah. So every baby has a potential to grow. And if it does not grow in the expected, trajectory, then we think that there is growth restriction. So fetal growth restriction is a leading cause of preventable stillbirth and poor neurodevelopmental outcomes in the offspring. And hence it is important for us to understand this. It's very common in clinical practice because 3 to 9% of all pregnancies may be affected by fetal growth restriction. And hence it is not rare, and every obstetrician will have to face this challenge sometime or the other. Fetal growth restriction may be the largest population-based attributable risk factor to preventable stillbirth, present in up to 30% of such cases. So that brings us to the challenge that what is the best form of managing fetal growth restriction? There is an algorithm that we start with, that you establish correct dating, assess the biometry and plot serial growth charts, and then assess Doppler's fluid and placenta to decide the time for delivery. Could we screen for fetal growth restriction? Could some tests tell us that which are the pregnancies which are at high risk of growth restriction? Yes. Now the time comes that we have to, think of preventing growth restriction. So you look at the various causes of growth restriction. Some of the causes are pure fetal causes like chromosomal abnormalities, genetic syndromes, malformations, intrauterine infections. So these are the causes which, if you screen for these causes, there will be growth restriction, but it will be secondary to some inherent fetal cause. And the management of that will be completely different. If the mother herself has clinical diseases, nutritional disorders, she's using some kind of drugs, or she's constitutionally small, those are a different set of problems which will require a different set of management. But the bulk of our problems and challenges in fetal growth restriction come because of placental factors, inadequate placentation. And this inadequate placentation can manifest as fetal growth restriction and maternal morbidity in terms of preeclampsia or other forms of poor placentation. So let me start with a case to bring all of you into the clinical scenario, that you have this woman who comes to you, gives you a last menstrual period. She says she's sure everything is okay, no history, nothing. She's an otherwise low risk primigravida who's come for a scan on a Monday morning, 8 a.m. clinic. And based on her date, she's 23 weeks, 6 days. But look at the biometry. Everything is falling less than the 5th centile. So what is this case? Unfortunately, we are on a webinar, not on an interactive session. Otherwise, I would have asked you what it is, and you would have told me this is severe early onset symmetric IUGR, because everything in the baby is looking small for gestational age. So all biometry is small, and then it's almost 4 weeks lagged with her date. So we think this is a case of severe early onset IUGR. Now what happens? The uterine artery Doppler is checked. That is also normal. So we do not know what is this cause, because there is early onset IUGR, symmetrical IUGR, but no uteroplacental insufficiency. So we are all worried. And then we start thinking of inherent ability of the baby not to grow, chromosomal abnormality, early fetal infection, early uteroplacental insufficiency. Something or the other definitely has to be the cause. Then you start checking her first trimester screening. Did she have a PAP-A level in the first trimester? Oh, no. She missed it because she was not sure of her dates. Any history of fever or rash? She's not sure. Medication intake? She's not sure. Hyperemesis? So, you keep on looking for causes and you're not sure what could be the problem in this case. Suddenly, the patient remembers that, oh, no, doctor, I forgot. It is not 4th of June. It is 4th of June. It's actually 4th of July. So what was the problem? The problem was wrong dates. She had not remembered her dates correctly. She did not have an early pregnancy scan. Nobody bothered telling her that there could be a difference in her dates. And now we see that everything is corrected because her biometry is actually falling in place. There was a 4-week lag, but actually it was the date. So before we start addressing growth restriction, my humble request to all obstetricians, please check the dates of your pregnant woman by an early pregnancy scan at 6 to 8 weeks, when all of us would be 6 to 8 millimeters. However fat or thin we may be later on in life, we all started our life with a single cell and we were about 6 millimeters at 6 weeks of gestation. So please check an early pregnancy scan and make sure that the dates are correct. Establishing correct dating is the first and foremost step of addressing the problem of IUGR. Then you come to other screening methods, maternal characteristics, history and examination. If a woman is small, in our country, that's very common. They come at 40 kgs weight, 35 kgs weight. So they will not have huge babies. They will have small babies, but they will not be abnormally small. They will be normally small because that is their trajectory. Fetal issues, aneuploidy screening, infections and structural issues. So every fetus must have a screening for aneuploidy, screening for maternal infections, and any structural issue should be dealt with a TIFA scan. Placental function markers. Doing a first trimester placental serum markers like PAP-A particularly, which is part of the first trimester aneuploidy screen as well, will help in assessing the ones who are at high risk of growth restriction. So if you can see, there is an overlap of factors which are used in screening for fetal aneuploidy, anomaly, as well as maternal preeclampsia and growth restriction. So with so many advantages, why should we not have a comprehensive first trimester screening protocol? And that is one of the important things we should do. The scan that we do in first trimester called the NT scan can be improvised by adding the uterine artery Doppler to it. And in the uterine artery Doppler, we need to see whether there's a good diastolic flow or there are early diastolic notches, and what is the mean pulsatility index of both the uterine arteries. So you measure the left and the right uterine artery, take the mean pulsatility index, and as a ballpark figure, if it is more than 2.6 in the first trimester, the mean PI is more than 2.6, it is likely to be more than 1.5 MOM for that gestation, and that would be considered as high risk for developing placental insufficiency. Nomograms are available for every gestation. You just have to look for them. They are available on perinatology.com. They are available free on the internet everywhere. If you don't have high-tech software, you can still access this. And high risk for all these poor pregnancy outcome conditions is related to a high impedance in the uterine artery. So the problem in fetal growth restriction basically is that the fetus is unable to grow inside. So if you know a definite reason why this is happening, then you can address it. If you do not know, then you have to remove the fetus from the intrauterine environment. If the fetus is at a gestation age where it can be salvaged, suppose it is 36 weeks, you don't worry that much. You just go ahead, deliver the baby, the NICU will take care. But if it is 26 weeks, you're in big trouble because you don't know what to do with this baby. You need to watch the blood flows inside. You need to improve the intrauterine environment. And that's a big, big, big journey that happens. Why is the fetus in danger? Because it is having a less supply of oxygen. And because of that, what the body does is it auto-regulates the blood flow, starts sending more blood to the brain, heart, and adrenal glands, and less to the kidney, gut, and lower extremities. So you see all the results of that. What do you see? You see echogenic bowel, the gut becomes hypoxic. You see oligohydramnios because the kidney is not producing enough fluid because GFR is less in the fetus, and the extremities start getting at risk of ischemia in time to come. So we have started using fetal Dopplers because this seminal papers told us that fetal Doppler changes occur about 2 weeks prior to the CTG changes. So a simple Doppler evaluation of the umbilical artery will tell you that the peripheral blood supply of the baby or the peripheral blood resistance of the baby is doing fine. If it gets worsened, you can see there is less diastolic flow, that is increased incidence, absent diastolic flow, and finally reverse diastolic flow. So that is the cascade of things going worse in the umbilical artery. Whenever the umbilical artery has positive diastolic flow, like in the first instance there, you will not have acidosis. You may have hypoxia, but you won't have acidosis. But once there is absent or reverse diastolic flow, the risk of acidosis increases, and acidosis can cause irreversible hypoxic ischemic encephalopathy. And therefore, we want to deliver a baby before acidosis sets in. What else can help us? The middle cerebral artery Doppler. The middle cerebral artery is a vessel which supplies almost 2/3 of the cortex of the fetus. And whenever there is a problem, you see here, the normal middle cerebral artery runs in a very high resistance. But whenever there is an hypoxia, the resistance of the middle cerebral artery comes down. And that is a sign of fetal hypoxia. So increased diastolic flow in the middle cerebral artery is a problem situation. We have another Doppler called the aortic isthmus Doppler. Now, it is not used very commonly in clinical practice still as a research tool, but it's a very good tool to help you triage that decision of whether to deliver the baby or leave it, because aortic isthmus is the area which is the it's a juxtaposition of the hypoxic, deoxygenated and oxygenated blood. So if the aortic isthmus is intact, the brain blood supply is still intact and the baby is likely to come out intact. Whereas if the aortic isthmus is abnormal, then the chances of neurological injury are high. So if you are at a salvageable gestation age, use the aortic isthmus to decide whether you can deliver today or wait for some more time. The final abnormality that happens in this whole cascade of Doppler changes is venous Doppler abnormalities. The ductus venosus is the direct inflow of oxygenated blood into the baby. And normally you can see it in the fetal abdomen as a very small vessel just before it enters the inferior vena cava. It is the most oxygenated blood supply to the baby. But when that becomes abnormal and you see absent A waves and reversed A waves, then you know that this baby is at risk of fetal death. So as long as the venous Dopplers are normal, there is a continuing compensation going on. Once the venous Doppler becomes abnormal, there is decompensation, risk of acidosis, and even death. So your decision for delivery in IUGR will depend on the gestational age and the degree of Doppler changes. If your gestational age is above 30 weeks, 32 weeks, 34 weeks, you start reacting at lower Doppler changes. But if your gestational age is less than 26 weeks, you will wait till the very end, because prematurity will become the bigger cause of concern in those situations. If your Doppler show positive diastolic flow and the gestation age is 37 weeks, you can even try labor induction. But if your Doppler flow is abnormal and the gestation age is less than 37 weeks, you will have to do an elective cesarean section. So this is a stage-based management protocol given in the paper by Figueras et al. And this is also freely available on the internet. If you find it difficult to get it, you can mail me, I'll send it back to you. And it's very, very clear how you can classify growth restriction into stage 1, 2, 3, and 4, depending on the degree of smallness and the Doppler abnormalities. And depending on which stage they fall in, then you can decide the time of monitoring and the time of delivery. So it's a very good sort of guidance for all clinicians. Now, what is the new concept that has come in now is that IUGR is not one entity, but actually two clinical entities. One early onset IUGR, the type I have been talking about so far, which is usually the onset is before 32 weeks and it has placental dysfunction. And you see that cascade of Doppler changes there. But now there's another kind of IUGR known as the late IUGR, where the onset is after 32 weeks. The risk of placental compromise is there. And because it starts so late, there is a serious risk of stillbirth. If you remember, a lot of you told, your patients that, oh, there is a stillbirth. I don't know what is the cause, because even the weight is okay. So if a weight is 2.5 or 2.6 kg and the baby has had a stillbirth, we cannot say that this baby did not have IUGR. Long back in our PGs, we read all small babies are not IUGR, all IUGR babies are not small. And that is exactly what comes across in your late IUGR, where a baby might be growing at a rate where it could have gone 3.25 kgs, but it went only till 2.5 kg because there was late onset IUGR. And at that point, something failed, the compensatory mechanisms derailed, and there was a stillbirth. This is the case of early onset IUGR, like we discussed the causes early. Here you see the placenta looks very big, Liker is very less. There are Doppler changes happening very early, and this is like 22 weeks. Now, you know that things are bad, but you can't do anything in this situation because you just don't know. You can't deliver a baby at 22 weeks. So you wait till 26 weeks. Unfortunately, this one had an IUFD, and that was something you just helplessly watched because you can't change the placenta. This is a case where, the woman presented with a low PAPE of amniotic fluid testing was done, karyotype was normal, but there was history of poor maternal nutritional intake. And here the baby continued growing along very, very small centiles, but it continued because they improved maternal nutrition and somehow the Dopplers were normal. She went up to 38 weeks and delivered a 2.7 kg baby. This is another lady who's 45 years of age, known case of diabetes and hypertension, low PAPE, 0.27 MOM, increased resistance in uterine artery Dopplers, absent and reverse diastolic flow. So lot of risk factors for growth restriction here. And here there were problems in the Dopplers. You can see a reverse diastolic flow in the umbilical artery, very, very low birth weight. But then you know that the diagnosis is very clear, but management is very difficult. This is a lady who had no comorbid conditions. PAPE was very low. And at 25 weeks, there was 6 centile early onset growth restriction. You just follow it up. And if other factors are normal, it just goes on. She delivered a 1.8 kg baby at 36 weeks with good fetal monitoring. We could carry on the pregnancy and deliver at a time when it was feasible. So every scenario will be different and your management of every scenario will be different. When it comes to late onset IUGR, till 32 weeks, you're very comfortable. You actually think everything is fine. And many of you might actually tell the patient, ab koi scan ki zarurat nahi hai. That is where we make the mistake. Because whatever happens in the last term, we do not know. And suddenly, if there is a fall in the growth centile, we will not detect it. Even the umbilical flows will not be that bad. There will be slight change in middle cerebral artery. So here, what clinches the diagnosis is the cerebroplacental ratio. Because you may not have a very, very stark change in the actual Dopplers, but very subtle changes in the intrauterine environment, which lead to a problem. So if you see the graph in late onset IUGR, you see there is a sudden flattening towards the 3rd trimester. And this is what is late growth restriction. The problem here is the placental villi are not mature. So you don't have that much placental resistance, but you have placental malfunction. And that is very important to know that there are different presentations of early and late onset IUGR. Early IUGR presents with stark problems in the Dopplers, whereas late IUGR can be a silent killer. So just to give you an easy example, I have put this sort of an example for you, that early IUGR is like student A. Student A is a poor student, does not score well. He gets very poor marks. You see C, D, always getting D or C grades. Whereas student B is an A student. She's always getting A grade everywhere. Somewhere in the near the final term, this student B gets distracted and she's failed the final exam. Whereas student A was always a poor student. So they started extra classes. The teacher kept on telling the parents that may not pass, may not pass, may not pass. So even if that child had failed, the parents would not have been surprised. But for student B, who suddenly now failed, parents are held, I mean, it's unanticipated. And that is how late IUGR works. You don't anticipate a problem, but you have an IUD. So remember that these Doppler changes that we see in early IUGR are not the same in late IUGR. Here, there will be a minor cerebroplacental ratio alteration and a biometry drop in the third trimester. So these changes that we see so classically in early IUGR do not happen in late IUGR. Can we do anything other than Dopplers? You can do a biophysical profile, and I think all obstetricians should learn how to do their biophysical profiles. Keep an ultrasound in your labor ward, and please look at the breathing movements of the baby. Please look at the liquor. Please look at the limb movements, because these are not rocket science. I mean, all you have to do is just put a probe there and see for the movements of those babies. And if you can see that your baby is intact inside, then you can decide your decisions. I mean, you make your decisions for delivery, because these monitoring methods will only help you prevent a stillbirth in these cases. Is there any treatment for IUGR? Well, if mostly it is the placental malfunction, and we still have no treatments. Sildenafil was once used, but there is a Strider trial which says there is no benefit. Lot of PDE5 inhibitors have been implicated in the treatment of IUGR, but you know what? There is an evidence of harm with the use of sildenafil, and hence it should not be used in treatment of IUGR. Upcoming treatments are vascular endothelial growth factor injection into the uterine artery, still in a trial prospect. The Everest trial, maybe at some point we will be able to get that to improve placentation in women. So far we don't know. All these things, bed rest, oxygen supplementation, nutrition supplementation, aspirin, beta blockers, calcium channel blockers, all this list does not work. Now what do we do? You are damned if you do, and you are damned if you don't. So what do? You just use the sieve of first do no harm, and see that what all can you actually do without causing harm. So you can improve maternal nutrition. You cannot give complete bed rest, but at least 2 hours in the day and 8 hours in the night. You can give oral hydration, and you can tell the mother to maintain kick count charts. Do a weekly antenatal checkup, 2 weekly Dopplers. If there are abnormal Dopplers, then twice weekly. Counsel and prepare for the NICU stay, and deliver optimally, balancing gestational age, hypoxia, and acidosis. That would be a reasonable plan, because it's very difficult to tell patients that I can't do anything. And another important thing is pre-pregnancy BMI optimization, managing food fats, optimal supplementation, proper dating, and first trimester screening, so that intervention can help. Serial follow-up. So fetal growth restriction is definitely a big problem. Early and late, we need to understand these concepts. Our diagnosis should be timely diagnosis, appropriate monitoring, and timely delivery. Every time we have to balance the odds of preventing whatever is preventable. So you have to deliver a baby, not just ensure survival, but also intact survival. So timely delivery is the key here. Good diagnosis and good monitoring is your challenge. Thank you very much for a very patient hearing.
I would just like to say one word, ma'am. Awesome. Anyhow, I would like to request Dr. Bedi for any special comments on this, ma'am.
Oh, well, hi. A wonderful presentation. Am I audible, Minnie?
Yes, ma'am, you are audible, ma'am.
It's beyond. I don't think any one of us could have done anything better than what she has done. So, Dr. Jimmy, hats off to you. Well, when we talk about 3 to 9% of the children who are afflicted with FGR, and these are the patients where we have to prevent stillbirths, and antenatal surveillance is of utmost importance. But as Dr. Chinmay said, that this is an old problem and concepts have changed, they're new concepts. So whatever she said about the ultrasound monitoring, be it the uterine artery, the umbilical artery, the MCO, whatever, I feel as obstetricians, we all have to know our ultrasounds well. We just cannot stick to the parameters and the biophysical scoring. We can send them to a radiologist for opinions, but I feel the way we can work up a patient is more important. And of course, you can take a second opinion from wherever you want. So I think that's a very important thing, that we as obstetricians should know ultrasound well. And of course, we should have a NICU backup. There's nothing more I could say about the treatment part, because every patient is very different and the dealing obstetrician knows the best. She's covered everything very well. But yes, I would again lay stress on the presence of a good ultrasound machine, which has a good Doppler machine with every clinic. Thank you so much, Dr. Chinmay. It was a pleasure listening to you.
Thank you. Thank you.
Let us move on to our second topic, a wonderful burning topic. We already know about the MTP Act. It has been amended time and again. For the second session, I would like to introduce the chairpersons as Dr. MC Patel and Dr. Manjeet Singh Sidhu. Who doesn't know Dr. MC Patel? But anyhow, it is a pleasure for me to introduce you, sir, on this dais. Anyhow, from your point of view, it is like showing a candle to the sun. He is a consultant obstetrician, gynecologist, and medico-legal counselor. He's been Vice President, FOXI 2018, Organizing Secretary, AICOG 2017, Chairperson, Ethics and Medical Legal Committee, FOXI from 2011 to 2013. He has been the President of Ahmedabad Obs and Gynae Society, a non-member national managing body, Indian Red Cross Society, and the National President, National Medical Organization 2016 to 2018. A warm welcome to you, sir. The second chairperson for the second session would be Dr. Manjeet Singh Sidhu. He is a senior consultant, obstetrician and gynecologist at Preeth Hospital, Bathinda. He is the president of Bathinda Obs and Gynae Society, with special interests in advanced vaginal and laparoscopic surgery. He is the member of MNAMS, FOXI, AGOI, JESI, IFS, ESHRE, and SFM. Worked as a classified graded specialist in Obs and Gynae at several major hospitals in armed forces, including the Command Hospital, Kolkata, Lucknow, Pune, and Base Hospital. He has presented posters and mainly in the as a panelist in the panel discussion for PCPNDT Act in AICOG in 2017. Welcome to both of you, sir. I would like to request Dr. Sidhu to introduce the second speaker, who's none other than Dr. Jaideep Tank. Sir, please.
Sure. It will be a pleasure to introduce him. Dr. Jaideep Tank, MD, DNB, DGO, FCPS, MICOG, is the Secretary General Federation of Obs and Gynae, FOXI 2018 to 2021, and a project lead of FOXI USAID projects from 2020 to 2024. He is the past president of MOGS. He is the Deputy Secretary, Asia Oceania Federation of Obs and Gynae, immediate past chair of FIGO, awarded the FRCOG honoris causa in 2020, is the past chair publication and newsletter committee of AOFOG. He is the past chair reproductive endocrinology and infertility committee of AOFOG and past chair of MTP committee of FOGSI. He is a consultant in Ashwini Maternity and Surgical Hospital and Center for Endoscopy and IVF, co-founder of Esperanza Healthcare, and program director and member of the board of ProFert IVF, and a visiting consultant for IVF. So we expect a wonderful lecture from Dr. Jaideep, as he has worked on MTP committee for FOXI. I think it'll be a pleasure to listen to him. Over to you, sir.
Thank you very much, Dr. Manjeet, for that very, very kind and very generous, I must say, introduction. I will just share my screen quickly. I hope my slides are seen and I'm audible well.
Yes.
Yeah, thank you, sir. Yeah. So it is, of course, a pleasure to be a part of this webinar. And I'm sorry. Yeah. Is my slide seen now? I think is my slide seen?
Yes, yes, it is seen.
Yeah.
The opening
Thank you,
slide.
sir. Thank you. It is, of course, always a pleasure to speak to the Punjab societies. I recently had the good fortune of visiting several of these societies, and I still have very pleasant memories of the very warm hospitality and the reception that I received from everyone there. Let me first begin by thanking the coordinator, Dr. Bini Bedi, for putting this whole program together, and acknowledge the presence of the eminent chief guests, Dr. Iqbal Singh, Dr. Parneet, and Dr. Gitanjali. I am not the Secretary General of Foxy anymore. But even now, when somebody starts saying Secretary General, I don't mind admitting that I get up at least halfway from my chair, because I've been a Secretary General for so long that it's become a bit of a habit to do so. And when I was Secretary General, and indeed for 9 years I was a office bearer of Foxy, one of my greatest pleasures was when collaborations happened. And when collaborations happened between societies, I could not be happier, because I think besides CME fellowship is an important pillar of any association of professionals. So I'm delighted that so many societies have gotten together for this webinar. And from Amritsar, there's Dr. Amritpal Kaur and Dr. Suparna. From Bhatinda, Dr. Manjit Singh Sidhu and Dr. Sunil. From Firozpur, Dr. Saroj and Dr. Dinesh. From Jalandhar, Dr. Surjit Kaur and Dr. Sukriti. From Ludhiana, Vidhu and Venus. From Nabha, Dr. Parneet and Dr. Sibhyapreet Kanwal. And from Patiala, Dr. Sarita and Dr. Ranjana Gupta. I'm also very fortunate that my session is being chaired by Dr. MC Patel and Dr. Sidhu. I think everybody knows Dr. MC Patel, the man in white, a lot of us call him, a true patriot and somebody who does so much work for the country and for the people of our country silently and behind the scenes. And of course, one of our most eminent medical legal experts. Thank you very much, sir, for agreeing to chair the session. And of course, the chairpersons of the previous session, Dr. Sujata Sharma ma'am and Dr. Bedi, both of whom I had the pleasure of meeting when I was in Punjab in December. Chinmay, that was a wonderful talk, very crisp, very pertinent, and some really great points you brought out. And then there's going to be a panel on critical care moderated by Priyankur and Vidhu. I don't know whether Priyankur's there, but I call Priyankur national coordinator, because whatever happens in the nation, he only seems to be coordinating. I don't know where he finds the time to coordinate so many programs. And then, of course, some excellent panelists, Dr. Kiran Pandey, Madam, Dr. Ami, Dr. Chechi, Dr. Saroj, Dr. Bharti Joshi, Dr. Dinesh, and Sukriti. So thank you very much for having me here. And I'm going to speak on MTP Act and update. And in fact, this presentation is not going to focus too much on the old MTP Act, or what is now the old MTP Act. We will make occasional references to it just to contextualize the presentation, but most of it is actually going to focus on amendments. But before I begin, can I request everyone who's here to kindly support me as I stand for the presidency of Foxy for this election year, a request I will be reiterating at the end of my presentation. So the structure of the presentation is that we'll first talk a little bit general about the MTP Act, the need for the MTP Act, etc. We'll then talk about what happens when lawmakers make laws in their silos and impose laws on us which have unintended consequences on good acts like the MTP Act. In that, we'll talk a little bit about PCPNDT and POXO, and then we'll move on to the substance of the presentation, which are the MTP Act amendments themselves. I don't know how many of you are aware, but it is my understanding that obstetrics and gynecology is perhaps the most regulated specialty amongst all medical specialties in our country. If you really think about it, I believe that we are actually regulated by many more laws than, say, for example, transplant surgeons, which leads me to think that successive governments and bureaucrats have always believed that what we do as obstetricians and gynecologists is perhaps much more difficult than, let's say, for example, a cardiac transplant or a liver transplant or a renal transplant. So I'm not really sure that's a backhanded compliment, but I can assure you it's a backhanded compliment I could do without. But because of the way these laws are drafted, because of the way these laws are implemented after being drafted in that fairly funny way, as obstetricians and gynecologists, we develop a fairly healthy cynicism or skepticism about the law, courts, judges, and lawyers in general. And for me, this is exemplified in this lovely quotation from The Deathly Hallows. I don't know how many of you are Harry Potter fans, but I'm a big fan. And I thought Deathly Hallows was a really fine book. And in that book, Scrimgeour asks Hermione, are you planning to follow a career in magical law? And Hermione says, no, I'm not. I'm actually hoping to do some good in the world. And because of this cynicism and skepticism that we have about laws, we tend not to look at the laws which govern us very carefully. And that's a pity. I mean, I'm not going to ask for a show of hands, but how many of us have really read the MTP Act cover to cover? Just think about it yourself. If you have not read it, please read it. For me, the MTP Act is actually one of the most elegant pieces of legislature which has come out of the Indian Parliament. It is short, it is comprehensive. It only tells you three things: who can do the abortion, who can undergo the abortion, and where can you provide the abortion. Simple. Moreover, it is also both an empowering act for women who seek abortion and a protective act for providers who provide abortion. So to understand this concept of empowering and protection, you need to look at how the MTP Act came into being via its timeline. The story actually begins in 1860, when we were still under the Britishers, and the Indian Penal Code of 1860, which the Britishers imposed on us, criminalized abortion. It criminalized not only those who provide the abortion, it also criminalized the women who sought the abortion. Now, because the demand and the supply both were made criminal, abortion went underground. And we know that when abortion goes underground, it becomes unsafe. The government realized this way back in 1964 and therefore set up a committee led by Mr. Shantilal Shah, who was a retired bureaucrat from Mumbai, and said, let's look at ways to reduce this morbidity and mortality. The committee worked for 2 years and produced a report in 1966. This piece of paper that you see on the slide is actually a paper from the original Shantilal Shah committee report. I had got it from the Library of Parliament when I had gone to make a presentation to some parliamentarians. After they worked for 2 years, they produced the report. And if you see that circled in red over there, you will see that even at that time, Foxy was represented in the Shantilal Shah committee. It was Dr. V.N. Shirodkar who represented Foxy for the proceedings of the Shantilal Shah committee. The government got the report, started working on the process to pass it through Parliament. It was finally passed in 71 and then adopted in 1972. But the Act is merely providing an overview of safe abortion, and then it delegates authority to the state and the central government. It's crucial to realize that the way we provide abortion in this country is not governed solely by the Act. It is governed by the Act taken together with rules, regulations, and the SOPs of the central government. So when authority was delegated under the Act, the central government got to make the rules, which are framed by the central government and ratified by each house of the Parliament, and the state gets to make regulations. Because remember, in India, health is a state subject. So whenever you make anything about health, the state needs to get some say in policy, and it gets it for abortions via the regulations. But the regulations are restricted to opinions and reporting and maintaining secrecy. And then, of course, there are SOPs. But there are instances when actually the rules sometimes have a much larger impact on our practice than the act itself. And this is a classic example. We are allowed to use mifepristone and misoprostol in this country because one explanation in one of the clauses of the rules talks about the use of mifepristone and misoprostol. Because of this, Mifi and Miso got legalized in the country, and now almost 70 to 80% of all abortions are provided with mifepristone and misoprostol. A great example of how rules can sometimes have an impact which is far beyond what the act said. SOPs, of course, are also important when they come from the government. We continue to provide second trimester abortion with mifepristone and misoprostol because the government guidelines, the CAC guidelines clearly say that that is the safest way to provide second trimester abortion. It also helps when professional societies come out with responsible guidelines. The FOXY ICOG GCPR on MTP, which came out in 2004, was drafted by me when I was the chairman of the MTP committee, and I'm quite happy that these guidelines have actually stood the test of time and have really not needed to be revised to any great extent so far. Unfortunately, sometimes lawmakers working in their own silos will make laws which have unintended consequences. And a good example of this is really the PCPNDT Act. Because of the way the PCPNDT Act is drafted, and more importantly, because of the way it's implemented, it has actually become a barrier, particularly for second trimester abortion. But ideally, there should not be any conflict between the MTP and PCPNDT Act. And I keep on having this argument. Okay, I'm standing for election, so let me not say argument, I'll say healthy discussion. Sometimes with our radiology colleagues who say that reduce sex-selected abortion and you will solve the problem of gender equality. And I say you're mistaken. You're mistaken because you won't crack down only on sex-selected abortions, you'll crack down on all abortion. It's a well-established fact that around 90% of women seek second trimester abortion for reasons other than sex selection. Now, if that is true, and you crack down on sex-selected abortions, then for the 10% of women who seek abortion because of sex selection, you will make 90% of women suffer. And I say the PCPNDT Act never talks about sex-selected abortion. The problem, it says, is not the sex-selected abortion. The problem is the detection of gender. And that's where the PCPNDT Act focuses on, and that's where we should continue to focus on. And then, of course, sometimes you have this POXO Act, an act which is needed, there is no doubt. But unfortunately, an act which conflates or confuses child sexual abuse with adolescent sexuality. The act, in effect, takes a Mai Baap Sarkar kind of an approach and says, adolescents, y'all are too dumb and immature to handle sexuality, and therefore let's ban all sexual activity for anybody under the age of 18. So all adolescent sexual activity for anybody who is under the age of 18 is a criminal activity in our country. And what is even more strange is that on the same government website where the POXO Act is there, there is also this wonderful document called the RKSK document, which says, of course, adolescent sexuality exists. Of course, it's important and adolescents must have access to contraception. And this actually creates a lot of conflict and conflation. So I'm just very quickly going to take you through a couple of questions that I commonly get asked about the POXO Act. Does a provider have a legal duty to inform the authorities if a minor girl is pregnant? The answer is unequivocally yes. Even if the girl has not expressed a desire to take action, even if the girl is a married minor, and even if the girl's age is uncertain. You have to report to the appropriate authority, and if there are child special services in your area, that is the appropriate authority. Otherwise, you have to report to the police, who are normally the appropriate authority under POCSO. How do you report? You report by writing, Miss So-and-so, aged about so-and-so, has come to see me and I find she's so many weeks pregnant. Take 2 copies of this, give 1 copy to the authority, take a received stamp on the other and come back to your clinic. Once you have informed the authorities, your duty as a provider under POCSO is complete, and you now move back from the POCSO Act to the MTP Act. If you really think about it, the MTP Act was actually very friendly towards adolescents. The MTP Act said that anybody under the age of 18 can get an abortion, provided she is accompanied by an adult, that means someone who's more than 18 of sound mental mind. So it says guardian and not legal guardian according to the Act. And for purposes of the Act, guardian is anybody above the age of 18 of sound mental mind. So it could be her boyfriend who's more than 18 years old. It could be elder sister, elder brother, favorite aunt. It does not have to be parents. So once you have informed, you can obtain consent and provide the abortion. You do not have to wait for the case to get filed under POCSO, an FIR to be lodged, or the court case to happen. You can go ahead and provide the abortion unless and until the authority explicitly in writing has told you not to provide the abortion. Another question which we get asked very often is, does the medical provider have a legal obligation to preserve the products of conception for abortion services for minor girls? Now, this has been a very controversial question with very varying opinions coming from all over the place. Some say yes, some say no. And this is from a consensus that was developed by IPAS and the Jindal Global Law School, which said that if you destroy the products of conception, there is no element of intent. And because there is no element of intent, it is not wrong to discard the products of conception unless and until you have been explicitly asked by the authorities to preserve the products and send them to the forensic lab. So this was the last time the Act was amended, and I'm quite fortunate that I was a part of the process for both rounds of the amendment, the earlier amendment as well as the new one. I'm showing you a screenshot of my calendar, and you can see the date 6th October 2008, and you can see what happened on that day. MTP amendments meeting at the Ministry of Health and Family Welfare, Delhi. That's how long it has taken for the amendments to come through. This was one of the first meetings, official meetings from the government I attended for the amendment to the MTP Act. There were several more meetings with other stakeholders before that, but this meeting was in 2008. The amendments got passed just now in 2021. Of course, a lot of advocacy has gone into it. I've written in several mainstream media about the need for the amendments. So those are my articles in Hindustan Times, Mumbai Mirror. Those are my editorials in the Hindu. I've been quoted in law journals. I've even published in law journals on the need for the amendments. This is an excerpt from an interview where I was interviewed by the Jindal Global Law School, one of the leading universities in the country, on my views on PCPNDT. You can read it online if you wish. I've also published in the International Journal of Obstetrics and Gynecology, and as I said, made presentations to parliamentarians. And when we made presentations to parliamentarians, the point that we brought out was that the question of abortion should not be an issue in the political arena. When a woman has to make this kind of decision, she should be able to see her doctor, not her lawyer, which is what was happening till then. We even visited the Prime Minister's office. We didn't get to meet the Prime Minister, but we met the person who was in charge of health in the Prime Minister's office. You can see that's Dr. C.N. Purandare sir, Dr. Jaideep Malhotra and me standing outside the PMO after meeting them, when we told them that these are all the things that we urgently need to do to make the MTP Act rational and make sure it is more in tune with times. We were therefore extraordinarily delighted and surprised that when the Act finally went to the Parliament, we found that in the draft, the government had accepted pretty much everything that we had asked for, except for that first one where we said abortion should be a woman's right. They had accepted everything. And in fact, when the debates in Rajya Sabha were going on, and that is Dr. Harshvardhan, who was the health minister at that time, mentioned Foxy in Rajya Sabha as one of the first stakeholders, or Foxy as one of the first stakeholders who was consulted before the MTP Act was amended, and that was quite a happy moment for Foxy. So this is the amendments to the Act, March, September, the notification, and then the rules came out in October, and this is what the amendments say. First of all, the amendments say that medical boards have to be formed. And for the first time ever within the Act, it mentions that abortions can be procured by medical or surgical methods. Now, I believe this is a bit of an underrated change, because when the Act itself says you can use medical or surgical methods, it then becomes easier to get rid of the confusion which occurs of off-label, illegal, etc. for MIFI and MISO beyond 9 weeks of gestation. Previously, we had to take one opinion up to 12 weeks and 2 opinions between 12 and 20 weeks for an abortion, which has now changed. Now you need only one opinion right up to 20 weeks of gestation, and you need 2 opinions between 20 and 24 weeks of gestation. What seems to be a small change, but is actually quite an important change, is that the word married from the clause of failure of contraception has been dropped. See, this is the wisdom of the people who framed the law. They said failure of contraception constitutes grave mental injury and therefore is an indication for abortion. They did not say you have to ask what contraception, which contraception, when contraception. The couple could have been thinking about contraception at that time, and that is also okay. Unfortunately, this clause limited the use of this indication only to married women. Now that word married has been dropped, and unmarried women can avail of this indication. As I said, it seems like a small change, but it's actually a very important change, because this means that the government has acknowledged that unmarried women also have sex, unmarried women also can have unplanned pregnancies, and moreover, unmarried women also need access to safe abortion. Within the Act itself, the duration or the gestational age limit for MTP has been extended up to 24 weeks. And now the next 2 changes that I'm going to show you are really quite remarkable in their width and wisdom. See who can undergo an abortion in our country up to 24 weeks of gestation. Survivors of sexual assault, minors, change of marital status, women with physical disabilities, mentally ill women, fetal malformations, and women with pregnancy in humanitarian settings or disaster or emergency. Literally, if you think about it, the only indication that has been left out is failure of contraception. This makes India's abortion law one of the best abortion laws in the world. And I mean, irrespective of politics, you have to say that this is really a forward-thinking step taken by the government. In fact, he also went ahead to say that anybody who's a degree or diploma holder in obstetrics and gynecology is automatically qualified to provide abortion through the gestational period. No fresh training or certification is required if you're a degree or diploma holder. And moreover, very importantly for logistics, if your facility is registered up to 20 weeks of gestation, you are automatically deemed registered up to 24 weeks of gestation. There's no fresh registration, reapplication, certification, or even inspection of the premises that is required. Another fairly dramatic change, I must say, is the formation of medical boards. And see how easy it is to form the medical board. You just need 3 people, gynecologist, pediatrician, and radiologist. Of course, you can have more people as and when you need. However, the basic requirements are very simple. The thing though is that there is a bit of a lag between this policy and implementation, because the medical boards have to be constituted by a gazette of the state government or union territory, and a whole lot of states have not informed this gazette to their authorities. Actually, that's why this happened around a month back. A couple called me up from Delhi saying, we are, IT professionals. We have a fetus 27, 28 weeks with very complex congenital cardiac abnormalities. And we want to get an MTP done. So I said, fine, go to the medical board, get permission and get the MTP done. They said, no, but we called you up because we heard you're active in the abortion space and there's no medical board in Delhi. So now we don't know what to do. So I said, all right, then I'll help you. And I helped them to go to the High Court. I helped them, make the arguments, etc. I'm not a lawyer, mind you. I'm just a practicing obstetrician. I just do it because I'm interested in the topic. And the big difference that has now happened when we go to court is that you no longer seek permission for the abortion from the court. That's a very important change. The appeal to the court has to be, please form a medical board. Because giving permission for the abortion is no longer in the court's power. The medical board, for indications of fetal malformations beyond 24 weeks, is now the correct person to give a. Of course, the couple went to High Court. Because it was the law of the land, on the same day, the High Court said medical board should be formed, and they have recently undergone the abortion safely. I just got a WhatsApp from them. Now see this absolutely remarkable change. No? Previously, if a woman beyond 20 weeks needed an abortion, she had to first go to High Court. And only a High Court would do. No district, sessions, magistrate, no other court will do. Go to High Court, the judge will make a hearing, ask for a medical board to be formed. The medical board could take its own time to give an opinion, 1 week, 2 weeks, whatever. In a sealed envelope, the medical board would then give that opinion back to the judge, and then the judge would decide whether the abortion should be permitted or not. And this, of course, took a lot of time. I remember I was asked for an opinion in one case where a 12-year-old girl, 12 years old, mind you, in a small village somewhere in our country. Parents were daily wage earners, used to go to the fields every day to work and make a living. Leaving the 12-year-old girl with the 60-year-old maternal uncle, not realizing that the 60-year-old maternal uncle was the worst kind of predator, a pedophile. He repeatedly raped this 12-year-old girl. Imagine the trauma. Until finally that 12-year-old girl got pregnant. Not having had the benefit of menstrual hygiene education, sex education, she didn't realize that she was pregnant. And by the time her mother realized that my 12-year-old daughter is pregnant, she was already 22 weeks. The parents took her to a local health center where they were told, sorry, abortion in India is allowed only up to 20 weeks. We can't do anything for you. And then began the round of authorities and courts and lawyers and medical boards. And imagine every time they go before someone new, every time they approach somebody new, they are reliving the trauma of what happened to her. 12-year-old girl. They finally reached the Supreme Court where I was asked for an opinion. But by the time they reached Supreme Court, she was 32 weeks pregnant. The court said 32 weeks, healthy girl, no malformation in the fetus, we are not going to give you permission. She then had to go to 38 weeks, 37 weeks and deliver that child by C-section. Imagine what that family has gone through. And now see the dramatic change that has occurred. When the medical board receives a request for an abortion, the medical board is bound to give an opinion in 3 working days. And if the medical board says this abortion should be done, the medical board has to ensure that within 5 days of receiving the request, the abortion should be provided. So imagine this really dramatic change where what used to take weeks and months together will now all get over for that troubled family in 5 days. Section 5A1, which accounts for penal provisions under the MTP Act, has of course raised a lot of concern. But remember, I told you that comes under secrecy, which comes under regulations. So the regulations have not been formed. We'll have to wait for a little more clarity. Some training requirements and need for opinions have changed, and there are 2 new forms. There's one form which the medical board has to fill when it gives an opinion, and the second one which we have to fill when we provide an abortion between 20 and 24 weeks. Of course, we are also waiting for the SOPs now. They have not really come out. These are the SOPs which I had the good fortune of drafting for the government of Maharashtra. This is the letter which where they appointed me the primary author for this. And these guidelines have also been submitted to the center. Hopefully, they'll take cognizance of these guidelines. In fact, after the MTP Act came out, I was asked to draft an op-ed by the government, and I was very happy when the op-ed was released as an editorial or a press note by the government. And if you go to it was released to all the high commissions and embassies all over the world. And if you go to the websites of these high commissions and embassies, you'll be able to read the op-ed I have written. And there has been some criticism saying that the amendments have not gone far enough, but I respectfully beg to disagree. I've just finished my tenure as the FIGO committee chair for safe abortion, and that's given me a little global perspective on matters. In America, supposedly the most advanced country in the world, there are entire states where not a single abortion provider is available. In Texas, the largest state in America, abortion is allowed now only up to 6 weeks of gestation. Can you imagine? Only 6 weeks. It's resulted in this funny situation where women who want abortion-related healthcare have to go from Texas to Mexico to get it, when healthcare should have actually gone the other way around. Of course, the road from policy to implementation is never straight, not only in our country, but anywhere in the world. It's always very tortuous, as this arrow shows. But we have to navigate it. We have to navigate it because almost all abortion-related deaths are preventable, and when abortion is performed by qualified people using correct techniques in sanitary conditions, it is one of the safest procedures. I'll ask you to remember your residency days. You're a freshly graduated MBBS, no surgical experience, and yet in the first or second week of your residency, you will typically be given a surgical procedure which will either be a gynec DNC or a surgical MTP. Now, for a procedure that is so safe that you as a freshly graduated MBBS student can do it under supervision, women are dying. They're not dying only in India, they're dying all over the world. We need to stop unsafe abortion. After all, history is her story too. Thank you very much for a very patient hearing. And let me again reiterate my request to you to please support me as I stand for the FOXY presidency. If you're watching this on your laptop and you remove your cell phones, you'll be able to scan that QR code. It will take you to my website. Once you're on the website, you can register your support for me. And I'm so happy, humbled, and thrilled to share that literally thousands of Foxians have already registered their support for me. There is a small video blog section. I talk a lot. My wife doesn't think so, but I do talk quite a lot. I've participated in more than 850 webinars since the lockdown began. And a whole lot of my presentations are actually present on this website. You can take a look. And if you would like, you can go to the Telegram channel, which I have set up, where I always put up whenever I'm speaking in a webinar. Thank you again very much, Punjab Societies. It's a real privilege and a pleasure to be here. And I'm looking forward to meeting everybody personally at some point in time. Thank you.
Thank you, Jaideep, and many congratulations for discussing the very relevant topic of today's day-to-day practice in a very simple manner. And you have rightly pointed out so many good amendments have come up in favor of our gynecologist friend who practice abortion services. As far as these rules and regulations are concerned, previously you gone with the history. In 1971, this original act was enacted and rules were formed in 1975. So after almost 4 years. But this time, what happened? When it was published in Government Gazette on 25th of March 2021, and government came with rules on 12th of October 2021. So within almost less than 7 months, government has come up with rules. So it has become much easier for us. You also pointed out very good part of opinion to be given by medical board within 3 days. Because in past, you mentioned one example also. In recently, there was news that permission was granted for abortion by Calcutta High Court for 35 weeks of pregnancy. And there was my interview, of course, it was in Gujarati. And they asked me, sir, this application happened to be at 24 weeks of gestation and judgment came at 35 weeks of gestation. So I told that lady who taking my interview, those days are gone now, madam. Now with medical board, it will be within 3 days only. And once opinion is formed by medical board, then termination will be happened within 5 days or so. So now that part is almost over. As far as contraceptive measures indication is concerned, you have rightly mentioned that previously it was available to married woman and her spouse. But now that word married woman is replaced by any woman, and that word spouse is replaced by her partner. So this indication is also now very wide to use for our gynecologist friend to take that indication also. So you have covered a subject very thoroughly, well, in a very simple way to be understood by all our delegates friends. So again, congratulations and all the best for your endeavor for FOXY presidency, because you are the deserving person, because I have seen you working in FOXY since long. And I have also privileged to work with you when I was vice president of FOXY, when I was chairperson of Ethics and Medical Legal Committee FOXY. And when we went for drafting this appeal in Supreme Court as far as PCP entity is concerned, I do admit that you were instrumental in that drafting of appeal also. So thank you, Jaideep, on behalf of organizers, having you as a faculty to deal with this subject in a very proper and lucid manner.
Thank you very much, sir. It was my privilege to work with you, sir. Thank you.
Can I have a question, sir? Yeah, this query.
Yes, sir.
We have a question for you, sir. So, Dr. Sidhu, would you like to take the question for Dr. Tank, please?
Yeah, basically in Punjab, in our society, some of my colleagues are calling me that now the amendment has been implemented. So when they are asking me that first it was registered for 12 weeks, my center registered up to 12 weeks. Now can I go and perform a MTP of 14, 20 weeks? I said, yes, you can, but I want to know.
Sir. There were two kinds of registrations in the second round of amendments in 2002-2003, where permission was given either for the center to be registered up to 12 weeks or up to 20 weeks. So if your facility is registered only up to 12 weeks, then you can do abortions only up to 12 weeks. If your facility is registered up to 20 weeks, then that 20-week registration now extends to 24 weeks. So it's very clear actually now that if the facility is registered only to 12 weeks, then you have to restrict only to 12.
Yes.
Of course, you have the option of applying again without losing your 12 weeks registration. So for example, if you're registered till 12 weeks, you can make a fresh application saying that you would like to extend the gestational age limit of your registration up to 20 or 24 weeks. You can do that. And it will not affect your previous registration, even if the new registration is not granted. That can be done. However, if it's registered till 12 weeks, then it's only up to 12.
Yes. Can I comment?
Yes, sir.
Yes. So it is prescribed form, that is form A. And in that prescribed form A, it is very specifically mentioned category A and category B. So just to mention, category A, that is up to 12 weeks, and category B, more than 12 and up to 24 weeks of pregnancy. But once your center is registered up to 20 weeks in past, then it is automatically re-registered rather. For 24, need to go for re-application also. But you rightly said, if it is for 12 weeks, then you will have to go for re-application if you want to extend. Otherwise, you have to restrict your practice up to 12 weeks only.
So I would like to request Dr. Sidhu to take up the question for Dr. Tank. Dr. Chinmay has put it in the chats, please.
Yeah, I can see the question. If you don't mind, can I answer it?
Please do. Sir, please go ahead, sir.
Chinmay is asked that for advanced gestation, is feticide an assumed event, or do we get specific instructions for that? Chinmay, the answer to that is that when I drafted the guidelines for the government of Maharashtra, of course, I had drafted them, they were passed by a big committee of the government. I had actually put in over there that any pregnancy after 24 weeks should get a feticide before you perform the MTP. And this was because it's extraordinarily difficult to deal with a fetus which is born alive after 24 weeks. And there are two things that one must realize for that. One is that if you use mifepristone and misoprostol to procure that MTP, very few fetuses will actually be born alive, even after 24 weeks of gestation. However, in case the fetus is born alive, it's an extremely awkward situation. The parents obviously don't want anything to do with the fetus, and you cannot leave it in a corner in your nursing home because your name will be splashed across the media the next day, how inhuman you are, and so on and so forth. So as a practice, what we follow is, if that fetus is born alive, then we send it to the NICU. The parents are told from the beginning that they have to bear the cost for whatever, but typically these MTPs are done for anomalies which are so grave that fetuses don't survive for a very long period of time. However, we took guidance from the Royal College guidelines, which said that after 24 weeks, when you do an abortion, you should do a feticide. And I had a bit of a tough time getting it accepted by our state government, but finally they accepted it. And I hope that when the central government comes out with its guidelines, it will say that beyond 24 weeks, you should do a feticide. So as of now, till the SOPs don't come, the medical boards are supposed to issue instructions to do a feticide for these patients. So when the medical board gives an opinion, the medical board is supposed to say that do a feticide first and then go ahead and do the MTP. That is the direction.
Jaideep,
yes, sir.
In this type of situation, there are so many other questions also. If patient is with private clinic and baby comes live, and parents are not ready to take charge of baby, and you shift patient to NICU, then who will pay for that NICU charge?
Sir, our patients are told that they have to pay.
One minute. The same question was asked yesterday only in one of webinar. So in this type of situation, you can set that baby in government setup where there is nothing to pay, because many a times it happens in private.
Yes, sir. But we tell our patients, I mean, sir, because of the work that we do, we get a lot of these abortions in our private practice. Sometimes the court also sends us patients, for the MTP. So we have developed this system where we do it this way. And as I said, two important things have changed when we go to court. One is, if we go to High Court, see, you don't need to go to High Court till it's beyond 24 weeks, first of all. Secondly, the only indication where the medical board comes into action is fetal malformation.
Yes.
Even now, if it's a case of rape, you will still have to go to High Court for permission beyond 24 weeks.
Yes.
But we made an analysis of all the cases that have come up before the High Court and Supreme Court seeking permission for abortion beyond 20 weeks. And we found that patients who are victims of rape or incest, etc., typically will present before 24 weeks. So that is why this limit of 24 weeks was kept for these indications. It is very rare that patients of rape or survivors of sexual assault will go beyond 24 weeks. So this is sort of very clear. And the big difference, as I said, is that you don't have to go to court if there is a medical board in place.
Yes.
So whenever we get an opportunity to go to court now, our plea should not be permission for abortion. Our plea should be, please get a medical board form. And that is a very big change which has occurred in the plea of what we should plead for when we go to court.
Yes. As such, in so many districts already medical boards are formed, and
there is actually a bit of a problem with that. I'll tell you, we had this discussion because these boards were originally formed under the Supreme Court order, which said that medical board should be there in every district.
Yes.
Now the problem is that these medical boards were formed under terms of reference which were very different from the terms of reference under the Act or the new rules. So these medical boards were formed to give permission for abortions beyond 20 weeks under the umbrella of the Supreme Court order. Technically, if you see, this medical board could be challenged for giving permission for an abortion because the Supreme Court order said that these medical boards have to give an opinion under direction of the High Court. Now, the new rules say that there is no need to go to court. So there is a conflict, you see, and this is the lag between the policy and the implementation. Ideally, what should have happened is that the rules come out and within a month or two, the states issue a gazette saying that every district can now constitute a medical board, let's say in the medical college. And the absence of a medical college, the collector should have the authority to form the medical board. This should have happened.
Yes.
But it has not happened. So we are advocating for it to happen. We are trying to come up with a paper which talks about the need for the medical boards, the procedure to set up a medical board. And I'm also working with another organization which plans to actually go to court. I mean, we'll wait, of course, we'll advocate with the government, etc. Otherwise, I work with another organization which uses legal means to increase access to abortions. And that organization, not me, but I'm just consult with them. That organization might go to Supreme Court and ask the Supreme Court to tell the government that now the law has been passed. You please make sure that medical boards get formed in 4 or 5 months. And I'm sure that within a year of the rules getting implemented, the medical boards will get formed.
Well, luckily in Gujarat, there are so many district boards are already formed. And just to mention that one gynecologist, one pediatrician, one radiologist or sonologist, they will be from government setup, and some 2-3 members they can appoint. So in Gujarat, in so many districts, they have appointed gynecologists who are practicing in private and who
That
are
is fine.
friends. So it becomes very easier for patients also to approach to him or her, and they will refer that case to medical board, and within 3 days they will have opinion whether pregnancy can be terminated or not. So it is good part in this amendment.
Absolutely.
But
sorry, I think
part
we are
of
taking a little.
Actually, we took on our Gujarat Sogo, then we approached government, please
Yes,
form
sir.
medical board in each district as soon as possible. And they have
Absolutely.
come up with so many districts with medical board formation. So
That is the way to go, sir. That
yes,
is the way.
exactly. So state, say for Punjab state OBGY society group may approach government and request them under this law. Now it is very official, and medical board should be formed in each and every district. And we rightly say, if it is medical college, fine. If not, then in district hospital also medical board can be formed, or they can invite members from outside also, from other than government also. If in that particular district hospital, if there is specialties not available, then they can invite from outside also. And in this medical board, one more good clause is there. In any given case, if they are in need that some more investigation are to be done, or one more opinion is to be taken by some expert person, then for time being, for that particular case, medical board has conferred with power to invite any other person to have opinion whether pregnancy can be terminated or not. So this is also good part as far as power conferred to medical board is concerned.
Yes. So I think there was another question that do we have to form medical boards for per case? The answer is no. Once the medical board is formed, it is formed permanently. The people on the board may change depending on the tenure of the people on the board, but once that board is formed, it's formed. And once the board is formed, the patient can actually directly go to the medical board and ask for permission for an abortion. You don't have to go to court anymore.
Yes. Patient directly can go, or a treating doctor can also on behalf of patient.
Even a doctor in private can refer. You don't have to be a part of the medical.
With all the investigation to support why this pregnancy should be terminated.
Yes. I think I have overshot time quite significantly. I'm sorry about that. I think Priyankur has been waiting. Priyankur actually switched on his camera after some time.
Very important discussion and useful in day-to-day practice of all our Foxian friends.
Yes.
In fact, everybody with me here would definitely agree to it, that it was a nice listening to the discussion between the you both and so many points to learn from it. Hoping for a better tomorrow for safer abortions, sir.
Yes.
Thank you so much, sir.
Well,
let's move on to the next topic about the panel discussion for today, which is about critical care in obstetrics. The moderator for the panel discussion would be Dr. Priyankur Roy and Dr. Vidhu Mudgal. Dr. Priyankur Roy, he is an India representative for VATOG FIGO 2018 to 2021. He is the National Coordinator for Perinatology Committee, FOXI, East Zone Coordinator for Infertility and Endocrinology Committee, FOXI. He is Joint Secretary of Siliguri Obs and Gynae Society, Organizing Secretary of the East Zone Yuva FOXI. We have already seen you, sir, that time in East Zone Yuva FOXI. He has published more than 60 articles in international and national journals, authored about more than 18 chapters, peer reviewer of various journals, presented more than 80 articles in various conferences. There are many awards to his name, and perhaps he has shortened the list and finally got the FOXI Dr. Nimish R. Shelat Research Award in 2020. I welcome you, sir, on this dais.
Thank you, ma'am.
The next moderator for the same session would be Dr. Vidhu Mudgal. Dr. Vidhu Mudgal is a consultant and director, Suman Hospital and New Life Infertility and Research Center. She's a lifetime member of FOXI ISAR SAFOG IFS. We know her very easily as president of Ludhiana Obs and Gynae Society. She's the member of Inner Wheel Group and Food and Drug Committee and Perinatal Committee. She has many awards to her name and organized various workshops, including the Save the Uterus workshop and Cervical Cancer Awareness workshop. She's working as a fertility expert since last 20 years in New Life Infertility Hospital. She's an obstetrician and gynecologist at Suman Hospital with special interests in infertility and high-risk obstetrics. Welcome you, ma'am. Dr. Vidhu, are you here?
Ma'am, she had given me a call. She's stuck up in an emergency, but she'll join, she said, once she's done with it.
Okay, sir, sure. Well, I will take the honor to include the panelists and invite them here on the stage it will be the first panelist is Dr. Kiran Pandey. She is the professor and head of the Department of OBGY, GSVM Medical College, Kanpur. She is the ICOG Governing Council member for 2021 to 2022. She is the president of Kanpur Menopause Society with the chairperson IMA WDW 2019 till date. She is the vice president of UP Obs and Gynae Society and UP AGOI. She is the ex-principal Government Medical College, Kannauj, and ex-president COGS and IMA. With so many awards, including the Best Teacher Award and the President Appreciation Award for Adolescent Health Committee at AICOG. Welcome you, ma'am.
Thank you, Dr. Mini.
The next panelist would be Dr. Amy Mehta. She's an associate professor, Department of Obstetrics and Gynecology, Srimati NHL Municipal Medical College, Ahmedabad. Welcome you, ma'am, to the panel.
Thank you, Dr. Bedi.
The next panelist would be Dr. Kanika Chechi. She's an obstetrician and gynecologist in Vardhan Nursing Home, Palwal, Haryana. She has graduated from LLRM Medical College with the master's degree from GSVM Medical College, Kanpur. Worked in MAM Medical College, Delhi and PGIMS Rohtak. She is presently working at Vardhan Nursing Home and IVF Center, Palwal, with special interests in infertility and high-risk pregnancy. There are many multiple publications in her name. Welcome, ma'am, to the panel. Vashisht, can we change the slide, please? Okay, the next panelist is Dr. Saroj Khanna. She is graduate from Medical College, Amritsar, with post-graduation from Medical College, Patiala. Worked at the Civil Hospital, Firozpur, Punjab. And presently she is running Khanna Nursing Home at Firozpur, Punjab since 1997. Special interests in obstetrics, done many complicated surgeries till now. Welcome, ma'am. The next panelist would be Dr. Bharti Joshi. She is an assistant professor obstetrics and gynecology at PGI MER Chandigarh. Her achievements were First Order Award as Silver Medal for MD PGI MER Chandigarh, various research publications in her name. She is a recognized reviewer of many PubMed indexed journals and has been invited as a faculty in many national conferences. She is the COVID-19 Nodal Officer from Gynae PGI MER Chandigarh. She is the Joint Organizing Secretary for North Zone Yuva Foxy 2020, which we are all looking forward to. I'm sorry, not 2020. She has special interests in infertility, endoscopy, and high-risk pregnancy. Welcome, ma'am. The next panelist would be Dr. Dinesh Pathak. He is working as a Senior Divisional Medical Officer in Obs and Gynae and NR Divisional Hospital, Firozpur, Punjab. He has special interests in high-risk pregnancy and maternal mortality with minimal invasive surgeries. He has been invited as a faculty of state and national scientific programs and conferences, presented and published various papers in national and international journals. He has received the CMD award twice for excellent work in Northern Railways, that was in 2009 and 2017. Contributed various chapters in Foxy Focus on RPL, recurrent pregnancy losses. He is the winner of quiz competitions of state and national level, including AICOG 2007 quiz. He has organized the first FoxyCon 2019 at Firozpur as an organizing chairperson and is the founder secretary of Firozpur Obs and Gynae Society. Welcome you, sir.
Thank you, ma'am.
Well, I now hand over the stage to Dr. Priyankur and Dr. Vidhu. Let's start with the panel discussion.
Good evening, everyone. Thank you, Dr. Mini, for that wonderful introduction of the moderators and all the experts who are present here today. Because I firmly believe that the panel today will be a learning curve for at least me, being the moderator. Plus our experts who are the panelists here who will be giving their views, their points of view of the day-to-day practice, and it will be definitely be a lot of good take-home messages for all who are viewing this program today. So first of all, respected Chief Guest, Dr. Iqbal sir, guest of honors, Dr. Parneet ma'am and Dr. Gitanjali Kaur ma'am, and of course the two learned speakers, Dr. Chinmay Ratha ma'am and Dr. Jaideep Tang sir, and the chairpersons, Sujata ma'am, Dr. G.K. Bedi ma'am, Dr. M.C. Patel sir, and Dr. Manjeet Singh Sidhu sir. So I welcome all of you, and it's a pleasure to be here with all the societies of Punjab today for this panel. Just share my screen. So I, on behalf of Dr. Vidhu Modgil ma'am also, welcome all of you to this panel on critical care in obstetrics. Ma'am is little held up in obstetric emergency, and she said she'll get back as soon as she's free. So our panelists have already been introduced. Dr. Kiran Pandey ma'am, Dr. Ami Mehta ma'am, Dr. Punika Chechi ma'am, Dr. Saroj Khanna ma'am, Dr. Bharti Joshi ma'am, Dr. Dinesh Pathak sir, and Dr. Supriti Sharma ma'am. Welcome all of you to this panel discussion. I would request all of you to kindly switch on your camera so that we can see you, and also you can keep your mic on when you're talking and not otherwise, so that we do not have any disturbance when we run this panel. Thank you so much. So to begin this panel, I would first of all like to say, women are not dying because of diseases we cannot treat. They are dying because societies have yet to make the decision that their lives are worth saving. And of course, for us obstetricians, challenges are what makes life interesting, and overcoming them is what makes life meaningful. So this will be a problem-based approach, just your day-to-day clinical practice, what you believe and what you do. We will not take it very long because we have already had a long session. We'll just wrap it up in a couple of cases with good discussion with everyone. It will be a practical implementation with experience-based learning today. So coming to the first case, a 32-year-old primary gravida with an uneventful antenatal course delivers at term with an episiotomy, resulting in the birth of a 2.9 kg male child with normal Apgar score. She has no risk factors for PPH. The placenta has not been delivered 10 minutes after the birth of the child. So I would like to first ask Dr. Kiran Pandey ma'am. Ma'am, how do you usually manage the first stage of labor?
Thank you, Dr. Priyankur. Dr. Vidhu, she will be joining us soon. And will take 30 seconds, but to thanking you, all the Punjab societies, Amritsar, Firozpur, Jalandhar, Bhatinda, Ludhiana, Na, Patiala, and all the delegates for giving me this opportunity. And thanks, Dr. Mini, for very kind words. Basically, the most important part is actually the management of third stage liver so that it doesn't go into the complication. And that is already defined as a clear-cut AMTSL. What used to be when we were residents, we were waiting for the signs of placental separation and then waiting for it. And if it is not delivering, then trying anything. Now the emphasis for everyone is the active management of third stage of liver. And what do we mean by active stage of management? That is the prophylactic in the use of injection oxytocin, 10 units intramuscular or IV after the delivery of the baby, number one. Secondly, the controlled contraction and the clamping of the cord. Uterine massage was initially included in this AMTSL, which is now not being not an essential part of it unless and until the uterus is very relaxed.
Perfect, ma'am. Well said. Of course, coming from a professor and I think who was teaching his students every day, this is what was expected from me. And thank you so much for this wonderful, wonderful input, ma'am. So I would next like to come to Dr. Ami Mehta, ma'am. Ma'am, what in your personal experience or in your private practice or the hospital, the medical college, how long do you wait for the placenta to deliver before any intervention, contemplating any intervention, I would say?
Yeah, good evening, everyone. Thank you for giving me this opportunity. Well, I work at an institute. So at our institute, usually the practice is, as the textbook is said, it's from 25 to 30 minutes. But as Madam rightly said, we do believe in the practice of AMTSL. And I would like to add one more thing into that. As per the recommendation, one should try for the baby to clean up with the nose and oral cleaning and directly put the baby over the maternal abdomen. So by doing that, what we call as breast crawl, it will also help in secreting oxytocin, and then it will also help in separation of placenta. That I would like to add on that point. But yes, from 25 to 30 minutes, that is the maximum period.
Perfect, ma'am. So what ma'am, she pointed out a very important and interesting point. Nowadays, the thing that we routinely practice, delayed cord clamping. As soon as the baby is delivered, put the baby on the mother's abdomen, wait for some time, because that helps the baby as well and also helps in preventing PPH, as ma'am has said. Also, with the secretion of oxytocin, helps in the separation of the placenta from the uterine wall quite easily, I must say. So, though Kiran Pandey ma'am has briefed a little bit about this, I would still like to go to Dr. Kunika ma'am and ask her about the rest of the points over here. What is your oxytocin of choice, ma'am? Drug, dose, route, and timing, usually that you practice. Kunika ma'am, can we request you to kindly unmute yourself?
Hello?
Yes, ma'am. So this is for you. Oxytocin of choice, ma'am. The drug, dose, route, and timing, usually that you practice.
For me, it is oxytocin only. We used to give oxytocin drip 20 units immediately after the delivery of the baby. And it is in the infusion form. And after that, if required, then only other oxytocics are given. Otherwise, I usually only give oxytocin.
Okay. Any other experts over here would like to add on some other points or some other experiences that you routinely practice?
Yeah. But I would like to say that in my practice, daily practice, as per emergency obstetric care protocol, we administer 10 units of syntocin IM at the delivery of the shoulder of the baby. So that helps in a better activity of third stage labor.
Well, may I have a word about it? It was initially that the oxytocin has to be given at the delivery of the shoulder, but now it is after the delivery of the fetus.
So that is one thing here. And the second drug which has become most common in use now is, as you have asked, for the control of the bleeding is misoprostol, which you can use like vaginally. Here we can't use because patient is bleed or the placenta will separate. So per rectal use is very much justified, and prophylactically 600 milligram, or if ever you therapeutically need it, then you can go up to 800 milligram. The third drug of choice comes injection prostaglandin. That is a later on if you have the availability, or if you are thinking that this patient might go into the postpartum hemorrhage, then you should keep ready. And of course, methergine is also not so much out. If the patient is not cardiac and not severely anemic, you can definitely add it also as another drug.
Perfect, ma'am. So can I ask the experts over here? Yes,
Dr. Priyanka. Hello.
Ma'am, can I just put in a question and you can answer this as well? Do any of you have any experience of using carbetocin in your day-to-day practice?
Yes. I have the experience of using carbetocin as a first line management of third stage. So we are actually doing it as a part of research project. So we are comparing both routes as well as dose of oxytocin in cesarean as well as in delivery. So till now, almost in 500 patients, we found very good results. So carbetocin is also being used as a first drug of choice in the third stage management.
Perfect. So coming from you, from that, of course, from the premier institute of the country, of course, we can understand where finances is not much of a problem, though it's marginally expensive, I must say, but definitely it's a wonder drug and it's doing wonders in our practices as well. In spite of giving oxytocin, especially in cases where you might have sometimes the doubt of whether to give that fluid, that extra bit of fluid which is required in the oxytocin infusion, carbetocin is doing wonders in those patients as well.
And it saves the cost of fluid as well as the drip set also. So if you calculate a 400 rupees drug of this carbetocin, so by going that calculation, it hardly costs 100 or 200 rupees more.
Plus the heat, it's not heat labile, so you can even store it, and then maybe the cost can also be talked about. True.
Yes.
So can I now next come to Dr. Saroj Khanna ma'am? Ma'am, are you with us? Okay, I don't think Dr. Saroj Khanna ma'am has joined us. So can I next come with this question to Dr. Bharti Joshi ma'am? And can Yes, any other drug you have already answered, but do you have any experience with AMTSL? As per the protocol itself, do you use something else other than oxytocin?
As we talk about tranexamic acid, we are not using it as a prophylactic drug till date. Yes, we are using it as a therapeutic drug for PPH. But if you ask me for the active management of third stage as a prophylaxis, yes, we are not using it as a prophylaxis, the tranexamic acid.
Okay, so anyone else with routine use?
Yeah, yes, I can have this idea because prophylactically, actually, to be honest, we are not using in delivery, but in all the cases of operative deliveries or other organic operations, we are using this tranexamic acid before before the surgery. I mean, when the surgery is going to be done, like uterus is going to be opened or something, if you give it that time, then the blood loss is significantly reduced. Or in the gynaec surgery, when you open the abdomen and give the tranexamic acid.
Perfect.
A normal delivery, we also using as a therapeutic only.
Perfect. So can I ask Dinesh sir or Kunika ma'am, whether your personal experience in your private practice, in a private setup, do you use tranexamic acid and has it been useful to you?
Yeah,
I usually use tranexamic acid only in cases of PPH, not as a prophylaxis. But definitely it is good, but not in prophylaxis.
Sure, ma'am. Dinesh sir?
Yeah. During cesarean, I usually prefer giving 500 milligram of tranexamic acid IV.
I see Mini ma'am is with us. So Mini ma'am, because we don't have Dr. Saroj Khanna ma'am and Dr. Sukriti ma'am with us, if you are up for it, if you could be a part of this expert panel, it would be great with your inputs as well. So can you pitch in your comments on the tranexamic acid as well?
Same here, sir. We are not using as a prophylaxis for obstetrics. I mean, especially for a normal delivery, vaginal delivery. In case we have had a instrumental delivery or a cesarean section, there are times when we use tranexamic acid as well. Of course, for gynecological operations, it is like wonder drug for, I think, all of us.
Absolutely. So this was a study, ma'am, that I had done when I was doing my post-graduation. This was published in the Jogi, a prestigious Jogi journal, about the role of tranexamic acid in reducing the blood loss in vaginal delivery. And I found out that it was quite very useful in reducing the chances of bleeding, or reducing the chance of PPH rather. So it was using the brass bead drape, a bag that is designed from our own Karnataka, one of the institutes, where the amount of blood is collected, and it was found that the amount of blood loss was markedly less, the amount of PPH was markedly less, and the drop in hemoglobin was also quite less. And to reiterate, along with this, the WHO recommendation for the prevention and treatment of postpartum hemorrhage, tranexamic acid, if you look at the last line here, the use of tranexamic acid is recommended for the treatment of PPH if oxytocin and other drugs have already been used, and this can also be used as an adjunct. As all of you have already mentioned, just would like to add on this points that have been said already. Oxytocin is the recommended uterotonic drug for prevention of PPH. It is 10 units IM bar IV, but routinely used as IM, but of course at the end of the delivery of the baby. Settings where skilled birth attendants are available, control contraction is done, but then there's a bit of a modification here. Control contraction should not be done where skilled birth attendants are present. Skilled birth attendants means doctors plus also trained nurses are also skilled birth attendants, and if they are present, this can be performed. Uterine massage is not recommended as an intervention to prevent PPH in women who have received prophylactic oxytocin. Postpartum abdominal uterine tonus assessment for early identification of uterine atony is recommended for all women, and CCT is the recommended method for removal of placenta in cesarean section, because of course we have a trained or a doctor present over there. Now, delivering of the placenta, as ma'am has mentioned, the third stage of labor lasts for 30 minutes. There are no signs of placental separation, but minimal bleeding is present in this stage. Firm contraction is given and results in delivery of the placenta. The woman collapses in the next 5 minutes. We have Dinesh sir around when this has happened. So Dinesh sir, can you tell us what do you think it could be?
Yeah, it happened with me once. I was delivering in the early morning during the pujas. I had the uterine inversion in a primary gravida while she delivered in the labor room. So it was detected, and I took her in the OT. And first of all, I put IV line, gave fluid, made the BP normal, and shifted her OT, and then went for uterine correction inversion by Holton's method, not used because operative.
We'll come to that. So you have initially managed the initial shock, and of course you have around, and you have to call people. That is a must in case of a uterine inversion. So next you have in hand, or you have Kiran Pandey ma'am who is there beside you. So you have called ma'am, and she comes and sees that the os is still open. So ma'am, what would you like to do in this patient now?
Thank you, Dr. Priyankur. Well, this is the very not a very common situation now these days, but initially, yes, patients do come with this type of problem many a times in our hospital, and they basically, if os is open, but what is happening? The most likely it's a sudden collapse, and you have mentioned that the cord has been firmly pulled, so that is indicating the uterine inversion chances. Now, first thing you have to assess, it is a partial inversion or it is a complete inversion. Shock, obviously the vitals have been managed side by side. So now the first thing, if it has happened into the labor room itself, you can deposit it manually. But you have to take care of this, that if the anesthetist is present, or if because under neuro patient can go into the neurogenic shock because of the pain. So that precaution has to be taken, and with that normal manually. What I would like to share with here all my co-panelists and with you, even I'm lucky to have or proud to have Dr. Kunika. She has been my student here. So maybe she might have had any experience of this, that I have always managed even immediate cases of prolapse, the inversion, or even those who have come up from the other referred hospitals by O-Sullivan method. It does a wonders. It is a very beautiful method because you said most non-invasive, you are not touching the uterus. Only thing, certain precautions and certain specific guidelines have to be used. You can deposit it any amount of any sort of partial or complete inversion without any damaging effect. So that's a wonderful thing. Of course, in the late cases, then it's a different thing.
Perfect, ma'am. So as people say that a teacher always reads the mind of the student, and me being the student over here, it was easy to read. My next question would be, is anesthesia mandatory before manual deposition? And ma'am has already answered the question, and she has beautifully said. So basically, the first things first, if you look at, of course, Dinesh sir has said, white bore cannula, we have fluid rushing in, we have the management of the shock, all that is done. And of course, with that, when we find that the os is still open, the first and the foremost thing to do is reposition the uterus. Anesthesia is not required, os is open. The simple formula that we usually follow, the thing that has come out last should go in first. So just manually reposition it, keep your hand there and start uterotonics till the uterus contracts on your hand. And also, as ma'am has said, the O'Sullivan's technique is another technique that can definitely be followed. Repositioning of the uterus itself will, with the vasovagal shock that has happened, gets corrected most of the times. And of course, it's better in today's day, if a patient is in shock or has collapsed, in our institute, it's better to have if you have a code blue, better to call the code blue team. They be with you and help you in managing this patient. So I would next like to come to, okay, so the os is closing now and the uterus has begun to contract on the fundus. The patient has been shifted to the OT now. So I'm coming to Dr. Ami Mehta ma'am now. What measures can you take to facilitate the reposition in this patient?
So patient needs to be anesthetized, and the choice of anesthesia should be general anesthesia, because you need the uterus to be completely relaxed. So anesthetist should be opting for a drug which is relaxing the uterus completely. And then again, one should try manually first from vagina. So through vaginally, if you are able to reposit it, then it is good. Keep your hand inside, start uterotonics, feel the uterus contracting between your two hands. Then you can decide and rather pack it through the gauze packs, and you can leave it with the uterotonics. If you are not able to do it manually, then only one should go for the other operative techniques. And once, yes, for a very important point, once the uterus starts contracting, ask the anesthetist to decrease the level of anesthesia. That has to be done hand in hand.
Yes.
Yeah.
That makes a lot of sense, because if the level of anesthesia is not decreased, there can be this complication of PPH, etc.
Yes.
Also set in.
Yes.
We have to definitely keep that in mind when we are doing it. Now, as Kiran ma'am has already said, Kunika ma'am being her student, so Kiran ma'am could not reposition it, and now it comes to a student who is in charge of the OT on that day, and there's a constriction ruling that has already formed and not negotiable. So Kunika ma'am, how would you like to go ahead in this case, ma'am?
My first preference is to give.
Ma'am, you're not audible clearly. If you can just talk a little louder, please.
Now it's clear.
It's better. Please go on, ma'am.
My first preference is non-surgical reposition, so I will prefer to give infusion so that by hydrostatic method uterus will go inside. But if it will fail, only then we'll go for the surgery, and in the surgery we can take out the fundus with the help of by pulling the round ligaments, and then it will come out. Rarely any other thing. Commonly it will be reposited if it is a fresh uterine inversion.
Okay, ma'am. So basically, the constriction ring has formed now. You will pull the fundus and you'll pull it out. But before that, of course, we'll have to cut the constriction ring because without that, to bring it back to facilitate the reposition might be a little difficult. So of course, you have then held the fundus, you have held the ligaments, and you have slowly pulled it out. So Kiran Bedi ma'am, in your experience, ma'am. So how do you prefer? Do you prefer anteriorly cutting the constriction ring, or you prefer to do it posteriorly? Ma'am, not audible. Kindly unmute yourself. Kindly unmute, ma'am. You're not audible, ma'am. It's okay. So, ma'am, I think there's some connectivity issue there. I would then ask Dr. Bharti Joshi, ma'am. Ma'am, what would be your modality and how would you like to manage this, ma'am?
There are two things. If their constriction ring is there, first they say in case of you want to do a non-surgical intervention, you just put a pressure on the fundus only. Don't press whole of the uterus. So that a narrow part goes up. Another important thing is, yes, looking at all scenarios and there is a severe constriction ring and you are going for a laparotomy. In that case, we prefer to give a cut on the posterior aspect, which has been mentioned in the literature. But till date, so many inversions have come to our institute and it was required only in one case. Because most of the cases we were able to do even with the constriction ring through hydrostatic maneuvers or through the manual reposition. So even in a case of constriction ring, they say don't give a pressure whole over the uterus. You just put a pressure over the fundus so that a narrow part first goes up and then the whole of the uterus can go up. Another important ththing, Dr. Priyankur, here I just wanted to highlight, we were talking about a patient whom we were attempting a manual removal of placenta and somehow we felt that inversion has happened. But here one thing important to be highlighted is that whether we were able to remove that placenta or the inversion has happened with placenta in situ. Because there will be two different things to be tackled now in this situation, because we have not talked about here that placenta was delivered and then somehow the patient. That is a very important situation where we need to address some important issues.
In this case, ma'am, we did mention that the placenta was delivered and after 5 minutes later only the patient collapsed.
Okay, thank you.
Yeah. So basically, as ma'am has said correctly, for all the viewers and the postgraduates, especially who are present here, if in case the placenta is in situ and you're trying to do a manual removal of placenta and the patient collapses, so you feel there's an inversion, do not first go in to remove the placenta, first reposition it back and we can go for the removal of the placenta after some time, after probably the patient's shock is corrected or the manual uterus has repositioned. Right, ma'am?
Yes, you have to reposition first and then try for removal if it is actually required at that point of time. Otherwise, you wait if she's perfectly hemodynamically stable and just look for the parameters of separation. So this is very important message. Don't try to manipulate it at that time because it is going to add on to the PPH and other shock factors.
Perfect, ma'am. So if you look at this flowchart, acute postpartum uterine inversion, first is clinical diagnosis and rule out any ruptured uterus if there are any. Immediate manipulative reposition, if possible, resuscitative measures to be started simultaneously. If the immediate manipulative reposition fails, then manual reposition in theatre under general anesthesia can go for the Johnson's method or the hydrostatic reposition, which could be the O'Sullivan's technique. If required, emergency laparotomy for uterine reposition can be done as mentioned by Kunika ma'am, Dr. Bharti Joshi ma'am. Mechanical pulling by the fundus from constrictive ring, Huntington's technique, or division of the constrictive ring posteriorly followed by the reposition, which is the Halton's technique. And if ultimately it doesn't work out, then obstetric hysterectomy has to be performed. But believe me, obstetric hysterectomy is one of the most difficult surgery to be done in a non-repositioned uterus because there are high chances of a ureteric damage, etc. that can happen in these patients. Post-operative management with resuscitation, antibiotics, and carboprost if uterus is intact. So can I ask any of our experts present here, any interesting scenarios would you like to mention in which you had any instances of, I see that Dr. Mini Bedi ma'am could unmute herself.
I could unmute myself.
Could you like to share any experiences of yours in which?
Yeah, I would like to share one patient which we had. She had been referred from outside as a case of uterine inversion immediately after the delivery. However, it took around half an hour for her to reach. So we could reposit her only under general anesthesia. But we had reposited her once with uterotonics overnight. The next day, we started reducing the uterotonics. But then she again we felt as if the uterus was coming out again. The inversion was again occurring. And then again, we started repositing it. We could deposit it in the ICU itself, then and there itself, and we could make out that it is coming out. We had to actually go for a CJ balloon tamponade in it. And that is what we tried in her, and it could save us from a very major OH, as you said right now.
Perfect, ma'am. So basically, to understand the facts that a relapse or a relapse in a case of uterine inversion is also something that we need to keep in mind because that's very common.
I would only like to share, Dr. Priyankur, one thing only, that in my 35 years of career in medical college, I have always been, I will just repeat it, that I've always been able to reposit the uterine inversions with a very simple O'Sullivan method. That was the time. And even of those who have come little late into the only thing, it takes more time, it takes more patience because the fluid leaks out. So you have to make a system that the fluid should not leak out. And the uterus distends and reaches even up to the epigastrium. And then once the contour is perfectly made, then gradually the leakage, we see that the fluid comes out. So it's a method checking your patience. Actually, you have to sit, but it becomes successful. And I think the young postgraduate should definitely know them.
Perfect. I was talking about the manual placenta. Any of you with any experience of the Pippinger's technique in manual removal of placenta? Do you routinely do it? Do you believe it helps, or how is it? The Pippinger's technique, in which, in case the placenta is stuck and we are not able to remove it, 50 international units of oxytocin is added in a 30 ml of saline, and it is given through the umbilical vein in the cord basically, and then it's pushed into the thing that usually says that it separates the placenta and it comes out. But there has been a recent RCOG article which says that it is not very useful. And also remember another point, because the thing is, see, some of us are in this private practice, and in a private practice, when this sort of a thing happens in the middle of the night, we are basically stuck because we do not know what exactly to do. So there are a few things which have helped us, our seniors in the past, and of course some things which we have learned and with our personal experience have helped us. So this is one such thing, I believe, though there are guidelines which say that it has not been of much help, but then the separation of placenta does happen. But of course, to remember one thing, that when you have a post-CS case and you have not diagnosed, it's an unbooked case who has come to you and you have delivered her and you feel that it's placenta percreta, accreta or something, please do not go in and do this maneuver, and because it can lead to a mess. So don't do it in those cases. But otherwise, maybe in anterior fundal or a posterior placental implantation, this can be definitely tried.
Dr. Priyankur, hello. May I add this to this intraumbilical injections of placenta? There is a latest issue. They say oxytocin doesn't work much, but they have talked about dissolving 200 microgram of misoprostol in a 30 ml of saline, and they say if you inject it, the results are better as compared to placebo or oxytocin. So these are the latest evidences. They are saying oxytocin is not of much help, but yes, misoprostol is of help if you dissolve that tablet in a 30 ml of syringe. Although we have not used it, but the upcoming literature is favoring this type of method.
Perfect. So basically, maybe with a few more studies, we'll definitely get it.
Yes.
That it can be routinely performed. Now, quickly coming to the second case, we've got probably another 15 to 20 minutes left with us before the panelists say that it's time to call it a day. So we come to the second case, a 36-year-old woman who has collapsed in the postpartum ward. She delivered by elective cesarean section 6 hours ago. The indication was a previous LSCS with unengaged head at term. Surgery was uneventful and ABGAR of the neonate was normal. She did not have any identified medical risk factors. So the nearest to her was Dr. Mini Bedi ma'am. So what are your urgent priorities in this case, ma'am?
So about this case, if we have delivered her by a cesarean section, we would first like to have a general checkup of the patient in the ward itself. Looking into the amount of bleeding which she has had, she would have been shifted to the ward by now. It has been 6 hours after the cesarean. And I would like to look for PPH, which is going on, to identify it, whether she's bleeding too much into the clothes itself. With taking care of the vital signs, the pulse, the BP and everything. If she doesn't have any medical problems before this, I think this should be a case of primary PPH.
Perfect, ma'am. So we'll come to it when we go through a few more scenarios with her. So one of the very important things I must say, ma'am, in this scenario is that in a post-op case, it is very important to keep the patient, at least for the initial 4 to 6 hours, in a place where there's someone who's monitoring. At least if there's a staff nurse or someone who needs to be around where proper monitoring is happening, that I think is very, very important. Because some of the times we have seen some in the periphery, some small institutes where there are no proper nurses, there's no one to take care of the patient, and you never know what is happening with her. So that is not something right in a patient care that I think should happen. So Dinesh sir, can I ask you this? What do you feel are the likely reasons for the collapse, sir, of this patient? So just to give you his brief again, she is a case of previous LSCS, I'm so sorry, delivered by LSCS, elective LSCS 6 hours before. Surgery was uneventful and she did not have any identifiable medical risk factors.
Yeah, the first cause, as Madam has actually mentioned, the PPH. First of all, you rule out PPH. Second, any embolism. Because she undergone surgery, so you have to rule out any embolism, either amniotic fluid embolism, or if she had history of any maternal cardiac disease or any other, then have to rule for any blood embolism.
Perfect.
So also should have to be kept in mind.
Okay, so we will be thinking of PPH and we'll of course be thinking of embolism as Sir is talking about, and amniotic fluid embolism, though it's an uncommon phenomenon, definitely has to be kept in mind when a patient collapses in the ward, all of a sudden, especially in a case of a post-operative case. So can I next ask Dr. Ami Mehta, ma'am? Ma'am, what would be your urgent priorities in her care, and what do you feel? How should we go ahead in basically in this patient? What is your urgent priorities and what will be a choice of vascular access in this patient rather than?
First of all, you have to call for help immediately. Immediately call for help, and then whatever IV line, obviously 6 hours postpartum, post-CS, there has to be intravenous catheter in situ. So whatever IV line is available to you, first start whatever fluid is available with you. If volume expanders are there, they are better. Otherwise, crystalloids, you just start running drip. And meanwhile, arrange for shifting the patient to the operation theatre. In that IV line, if you are able to just, this is a uterine atony, then add on oxytocin and simultaneously alert your anesthetist team, call your OT prepared, and decide accordingly after examining the patient. But yes, simultaneously things should be going on, call for help, give rush of IV fluids, whatever is available right now on that moment. Once the help arrives, send blood for cross-match if not already sent. Mostly the lab would have kept it prior to cesarean section. So ask for PCVs.
Perfect. Sure. So another question, important question I would like to ask over here, because Dinesh sir comes from Firozpur and I believe sir does private practice. So sir, can I ask you this question? Do you routinely for your cases keep blood cross-match when you plan for elective cesarean section?
I don't have the routinely. I am in the government setup. We do not have any routinely. We don't keep for blood cross-matching, but it is available as soon as we required. In an hour, we can get the blood from hospitals.
Anyone over here from a private setup, can I just ask you, do you routinely think routine cross-matching of blood is important, or do you keep it routinely cross-matched?
I would like to answer Dr. Priyankur.
One, ma'am.
I am working in a small nursing home. Usually, we always keep one blood arranged for every patient who is going for surgery, even if hemoglobin is okay. But if hemoglobin is less than 8, then we keep blood available and cross-matched. Otherwise, we just keep available that it is available if we need, but not routinely cross-matched for every patient.
Absolutely agreed. I don't know, there are a minimum. Do you want to say something? I think you're unmuting yourself.
So as we said, this is a previous LSCS, previous cesarean. We really don't know what is going to come out of the surgery. So asking for the availability with the blood bank is always safer before proceeding for the surgery. At least if not cross-match, at least ask for the availability with the blood group already in hand. Arrangement and then other things can follow if in case required.
Agreed. And I see over here, Ami ma'am, you want to put in a word? You have
a... Yes. One must send sample of patient's blood ready to cross-match whenever the needs arise. And that has to be kept with the lab preserved for at least 24 hours post-surgery. That is one message I think I would like to clear, because at that time when you are in need of blood, collecting the blood, sending it for cross-matching, that will waste another 10 minutes. In an institute, in a private setup, I don't know, sending it toward the laboratory which is little far from your setup, it would waste of time.
Agreed, ma'am. I do see over here that the professors from the medical colleges, Dr. Bharti Joshi and Dr. Kiran Pandey ma'am, are not nodding their head. Probably they do not agree with us with the fact that routine cross-matching of blood for all patients is not required. But then, of course, people who work in small setups They know how difficult things go when it's a case of a PPH, or when it gets really difficult in the middle of the night when you don't have blood with us. Then the message is not. There have been one report that has come from one of the European countries which say that routine blood cross-matching is not required in a cesarean section. But then again, considering the scenario, what sort of a setup you're working with, how long will a blood take in case if you land up in trouble, are scenarios which you need to look at your day-to-day scenarios rather than following studies. Because if there's a PPH, if the problem is in trouble, then you are in trouble and the study will not go to save you at that point of time. So I think that we need to keep in mind, and this is for all the people, the postgraduates especially, or the junior people who are working in periphery setups. Do keep that in mind. In case if you feel it will take time for you to get blood if required, then please do arrange it from before itself. And as everyone has already mentioned, hemorrhage and embolism being the commonest causes, the things that we need to get ready. And as ma'am has correctly said, IV fluid, whatever is in hand, do start it first and then think of what sort of a fluid it is, because fluid going inside is the most important thing initially if you do not have a choice.
Only thing, colloid should not be given without taking the blood sample. Otherwise, this will affect it. So that is very important. Yes, and the hemoglobin, if the patients are taking antenatal care, then we have to keep a track that their hemoglobin is built up timely, because as very rightly said, hemorrhage is the most common cause of the maternal mortality. So, and in the medical colleges, the patients come with a very low hemoglobin, what we are managing. So, and I mean, coincidentally, we are always arranging the blood.
Wonderful. So now we move on to Dr. Bharti Joshi, ma'am. Ma'am, the abdomen is distended. The resident has called you. The abdomen is distended, very tender, and there's a tachycardia of 2+ that is present. You have planned this patient to take her up for a laparotomy. So what preparations would you do that should be in place, or you tell your resident to do it, or how do you want to prepare her before you go ahead with the...
Okay, so from the clinical findings, it is evident that the patient is having hemoperitoneum and patient is in postpartum collapse. So side by side ongoing resuscitation has to be there. Then we have to inform anesthesia people, we have to inform blood bank that we don't know what will be there inside, which vessel is bleeding, how much blood will be required. Then senior professionals, an alarm has to be raised. So these are the preparations, and even ICU backup has to be ready because she is a patient who is a postpartum collapse. She will require invasive ventilation. She may not come out from anesthesia because of all these issues. It is not only blood has to be arranged. We have to arrange all other components because it has to be given in we may have to follow the massive transfusion protocols. In that case, we have to give all the components as well as blood into 1:1:1 ratio. So everything has to be in place. Senior anesthetist and obstetricians, ICU, even other urologists. Somehow we feel that in drop we cause some kind of injuries, or there is a kind of broad ligament hematoma expanding into ureters and other things. So multidisciplinary approach will be required along with all preparations of these patients with simultaneous resuscitation going on.
Perfect. So basically the important points, yeah, Dr. Mini has raised her hand. Ma'am, please go on. Please unmute yourself.
Ma'am perfectly said that we will be managing the patient, but out of this whole busy thing, we'll have to take 2 minutes to talk to the patient's relatives and the consent, whatever can happen, whatever, as ma'am has said, whatever can happen inside and what we may have to do. For that, consent is also required. We may have to talk to the relatives for 2 minutes.
Absolutely. Not 2 minutes, I would say at least.
I think a better time, of course, but then, I mean, we are in a hurry, so I just said like that.
Because right now, the most important thing, because we have Dr. Jaideep Tank sir with us, we have Dr. MC Patel sir with us, and they have talked about the medical legal bit. And it's very, very important. Documentation, and counseling. Because without a counseling, we are in a soup. Without documentation, we are in a soup. Whatever we are trying to do for the patient, first thing we need to remember, we need to try and save ourselves as well. And in the court of law, if something is not documented, it means it is not done. So we will definitely have to try doing that. Kunika ma'am has raised her hand. Ma'am, can I ask for your comment?
I just want to add one thing. If you are working in a small setup, as I am having a small setup and not very many ICUs, or even not in my hospital, not nearby. So before opening the patient, I think we should also check whether we will manage it or not. Because sometimes if ICU is not available, referral is a better choice rather than to open the patient and then there is a chaos. So we should check whether we can have backup for the ICU and other things. Otherwise, in my practice, we used to refer the patient after stabilizing. And that's why we used to monitor the patient strictly in the post-op period. You used to keep multi-para monitors for every patient, because staff sometimes missed the vitals. So we used to keep a monitor on till 4-5 hours post-surgery. And if it is available facilities, definitely you can go for surgery, but we should check, because in small setups, sometimes it is very difficult to open the patient.
So post-op management is the most important part. Proper post-op backup, if you don't have, refer to a patient where she can be taken care of. Post-op is what the statement that makes sense. Absolutely. Dinesh sir, your hand is raised. Can you ask you what you want to say?
Yeah, Reza, I would like to ask everyone here that I have got 2 cases of similar situation, hemiperitoneum post-operatively. But when I opened the abdomen, there was no sight of any bleeding or any, I couldn't find any bleeder, but the abdomen is full of blood. Once I have done it, I put it there, it was okay. So has anybody here come across such conditions, and can they share anything?
Yes, multiple times, Dr. Dinesh. Hello.
Yes, ma'am, we can hear you. So basically, me being the moderator today, I can just say that there's no question that comes to me. I only ask questions today.
This happens multiple times. We receive so many patients with massive hemiperitoneum, with the hypotension and everything. When we open the patients, there is nothing visible as such. But when you drain the hemiperitoneum, patient somehow recovers. Even that, they say, because of draining the hemiperitoneums and taking out even small bleeders, they may not be the cause of that bleeding. That systematic inflammatory response syndrome is not there. So somehow that patient recovers, because it may happen that because of that pressure tamponade, if some bleeder was there in the initial, which led to the bleeding, has automatically stopped over a period of time. So when we open, there is nothing inside. But that draining of hemiperitoneum is going to give us a benefit, because all the drained blood will not cause a systemic inflammatory response syndrome. So the patient somehow recovers also. So we have experience of such patients. Many patients, they come and we don't find anything inside.
So the important thing over here is, once you do it for your own satisfaction plus the better care of the patient, I think it's very important to put in a wide bore intra-abdominal drain. Please do not go ahead and put in such cases. Suppose you have done a re-laparotomy, you have opened her up again, you have seen it. Do not put a rise tube. It's seen in some of the periphery setups where they put a thin rise tube, thinking that why to put a drain, why to make another incision. But believe me, if with a clot the drain gets blocked, you do not know what's happening inside. It's much better to put a wide drain so that you can see what exactly is happening. And I see a hand raised from Dr. Ami Mehta, ma'am. Ma'am, I just put in the next couple of questions, and this was for you as well. So maybe you can put in your point and you can answer this as well. So what is expected in laparotomy in the intraperitoneal content and about the uterus, and what surgical measures do you think will be useful in this patient?
Okay. Yeah, why I raised hand was, if our patient is collapsed but still not unconscious, she is conscious, able to understand, then we should take consent of our patient also regarding laparotomy, and of course for the SOS need for obstetric hysterectomy. This was one point I wanted to highlight. Just rightly, as you said, we need to save ourselves also. So if patient is conscious, we need to take this consent. Right now, what is expected at laparotomy? Yes, of course, one may find some bleeding vessel from our uterine incision site, or there may be some hematoma, broad ligament hematoma, because ours is an intraperitoneal bleeding. But sometimes we do not find any intraperitoneal hemorrhage, and still there is PPH. At that time, we need to reopen the uterus to rule out any endometrial tears left behind. And this we had encountered multiple times in our practices. At our institute, patient referred from private hospitals because of collapse due to PPH. Many times there wasn't any intraperitoneal hemorrhage, but because of unnoticed, unsutured endometrial tears left behind, patient led to bleed, and then onwards to the vicious cycle of DIC.
Okay, so
now,
say just to put in ask you a point, because the thing is, now sometimes we say that we take the myometrial sutures and we leave behind the endometrium and we do not suture it, but then probably you're talking about the posterior wall or some placental bed bleed that is continuously bleeding and causing this sort of a problem where we
yes, exactly, not at the incision site, but from the uterine overall surface.
Correct, absolutely. Yes, ma'am. So surgical measures, you feel that would be useful, ma'am? If we can just ask you this, and then followed by Dr. Kiran Pandey, ma'am, if you could just highlight about this this question.
Okay. Shall I answer or Kiran ma'am is going to answer?
You followed by Dr. Kiran Pandey, ma'am.
Okay, fine. If we are finding any hematoma, of course we need to drain that hematoma out. We have to take care of the surrounding structure. Mostly, we are liable to encounter either bladder or the ureter.
A little later, ma'am. Other than the hematoma, is anything else that we are seeing? Suppose there is a collection in the intraperitoneal cavity which is there, or you see that there is some bit of tear which is not being sutured, or there is some bleeder somewhere. So what?
Yeah. So first of all, drain whatever hemorrhage is there. Clean your operative site. Try to find out any active bleeders. If you are finding one, then secure it first. And then again re-explore the cavity to find any hidden bleeders. Okay.
Sure, ma'am. Ma'am, can I go to Dr. Kiran Pandey, ma'am?
Yeah. Basically, the 2-3 things can be there. One is your angles of the incision have not been yet if properly secured. They do bleed, they can bleed. So that is one thing we tell our residents always, when you are taking a suture, always ensure that you have taken the angles properly. Secondly, it is a case of cesarean section, so the incision, there can be extension if the proper that has not been checked, so that has to be seen. Thirdly, of course, as already told, that there can be, because of this bleeding which has not been detected, and the hematoma can form. Now that hematoma will become very dangerous, because all the time you have to take care of the ureter which is there. And similarly, even the lower uterine segment, if there is extension, then you have to take care, because the trigone of the bladder rests on the anterior part, the lower part of the lower uterine segment. So that, bladder has to be properly mobilized to see that you have been able to reach to the lowermost extent of the tear or not. Because this happens, and that time we do take the use of stay suture, like if one suture has been taken, then hold it and then go beyond below that and then hold that, and so ultimately you have to reach to the end and taking care of the bladder. Then of course there sometimes can be like so many sutures that the tissue might have become swollen, friable, edematous, because you are opening for the second time. So that part also can bleed, and you have to take care. And of course, so identification of the actual cause of the bleeding has to be there, and management. And one thing which my co-panelist was talking about, the uterine surface, if it is oozing, there you can this balloon tamponade helps very nicely. Or you can take Cho sutures or Heyman's sutures if the uterus is not contracting. So those sutures can definitely help you tying those bleeding points. So that is very important.
So as all of the experts have correctly mentioned about the things that we can do, probably a couple of other things also. We of course know about the ligations, the vascular ligations, stepwise vascular ligations that we can do. But of course, to sum up this, I would say, get help from an obstetrician, surgeon, anesthesiologist, whoever is there near you. When you find a case which is admitted under you and is complicated, always call for help. Have someone with you when you're operating again, because sometimes we do not have that sort of a strength in ourselves to manage the complication ourselves in case we have landed. Anesthesiologist lab and ICU backup has to be there. There has to be crystallized blood products that has to go in. If there are any lacerations, repair it. And also in case if for the surgery, ligate the vessels, you can do the uterine artery ligation followed by the internal iliac and the ovarians. And of course, finally, hysterectomy may be required. So Dr. Mini ma'am has raised her hand, ma'am. I guess you want to say something?
Dr. Pregu, just before that, one thing, that besides uterine artery, that the co-anastomosis with the ovarian artery is also there. So that should not be missed, because otherwise it will not be controlled by the uterine artery alone. Internal iliac is obviously a very good thing. We have been doing in our department for years, but I mean, it depends on the skill of the person, and unless and until you know it and you've done it earlier, you cannot do in this mess.
My
So
teacher,
stepwise will become.
My teacher, Dr. Vineet Mishra sir, always used to say, keep practicing something when you're in a cool situation. Do not go and jump and try to do something when you're in an emergency, because you will not be able to do it.
Yes.
So practice it in a cool scenario, and then maybe not tie the internal iliac, practice it, dissect it out, maybe try like it will be required when you need it. I saw Dr. Mini ma'am with her hand raised. Ma'am, do you want to comment? You're muted, ma'am. Kindly unmute yourself.
I just wanted to add, Dr. Branko, that it is okay to have a complication. Like we as doctors, we are also human beings. It is okay to have a complication, but it is important to identify it and manage it in time for the patient's sake.
Perfect. As a famous saying goes, it says that only people who have not complicated are people who do not operate, or people they have forgotten their complications. Other than that, everyone will have complications. So this case, just the last bit of it, is a 6 centimeter broad ligament hematoma from the extension of the uterine scar. So this patient has landed up in Ahmedabad at Dr. Ami Mehta ma'am's unit. So ma'am, how will you manage this?
So we need to reopen the visceral peritoneum if already sutured, then drain the hematoma carefully, identify the ureter. Sorry.
Ask you, ma'am, do you routinely suture the visceral peritoneum in all cases?
Yes, I am in favor of suturing visceral peritoneum, the standard 3-layer uterine closure. But in our institute also, some people, they do not resuture the visceral peritoneum. But if one has sutured it, we need to reopen, then drain the broad ligament hematoma, identify the bleeder, and suture it only after confirming where you are taking your sutures, taking care of bladder and ureter, of course. Because once there is hematoma, the tissues are friable, anatomy is little disturbed, and one can end up taking sutures very near to the bladder and ureter if not involving them. So by kinking or later on damaging it can be one of the most common complications. And yes, one more thing, in broad ligament hematoma, we must take care of the posterior structures.
Yes.
So better thing would be eventering, taking the uterus out of the incision, taking care of the bowel by isolating them behind by some gauze pack or instrument.
Perfect.
Yeah.
So basically very, very important to take care then that things go fine. Not have an anesthetist above your head who will jump and who will say that finish it fast, we do not have time to do all these complications now. Have a cool head, have someone with you who will be there as a support. Even if it's a junior colleague of yours, I think that's how it will help. Now we know the difficulties of it, especially when we are working in a smaller private setup. Kunika ma'am, you say that you work in a private smaller setup. Can I ask you what would be the difficulties that you may anticipate in a case where you're doing an obstetric hysterectomy?
Actually, sir, as I am saying, I am more in favor of early referral. So I am not doing obstetric hysterectomy at my place at all. Once I met one patient with broad ligament hematoma, and that in fact I missed because that patient was showing all the features of shock, but I am not able to find out where she was bleeding because abdomen is soft. There is nothing even on paracentesis, not on ultrasound. Nothing is coming out from the uterus also, but patient is going in shock. The only thing which I noticed later that uterus is shifted to one side. And that was the reason that later on laparotomy it came out to be broad ligament hematoma. So for me, hysterectomy, I think you should ask someone else because I'm not doing routinely obstetric hysterectomies.
I will, ma'am. I will ask someone else, but I must totally say over here, I think Dr. Kiran Pandey ma'am must be feeling very proud of the fact that you have the thing in an open forum to say that there are certain things that you don't do and you openly admit it. That's the most best thing that we can do to ourselves, be true to ourselves and not do something, not attempt to do something which we do not know. So there's something better to do because that will be good for our patient as well as for us. Especially in this.
Doctor, I definitely say I worked in a MAMC as well as in Rohtak Medical College, and when I came to private practice, it appears for me like I can do everything. But slowly I realized that it is a teamwork, and never put your hand in a thing which you can't manage, because you don't have team. We need ICU, we need surgeon, we may need anyone. So for from my side, it is a sincere advice to check and recheck again whether, if it is a high risk patient, my opinion is it is always better to refer or explain the patient. Even if then want, only then you do the patient. Otherwise it is always better to refer the high risk patient.
Perfect.
So I don't do.
Wonderfully said, ma'am. Very, very nicely said, because of course it makes sense to refer a patient when we are not able to do the case, or you put in a hand where we will not be able to manage the patient well. So Dinesh sir, I would like to put the same question to you. What are the difficulties that you would anticipate in performing this obstetric hysterectomy?
Yeah, first of all, the broad ligament hematoma. So we will have difficulty in identifying the extent where to put the clamp laterally on the corner structures. So once you dissect it and open it, then they likely the bleeding, the blood which is there, like will start bleeding, and it will have face difficulty in putting the next clamp on that side. And there is high chance that we can clamp the uterus might be injured here.
Yes, sir. Perfect.
Because post-cesarean and the friable, the tissue becomes friable. So while repairing, I have missed 2 times that the anterior and subtotal hysterectomy, the anterior and posterior wall was not clear. Once I have sutured it, then I realized that I have missed the posterior uterine wall. Then I have to resuture it again. So these are the common which I have faced.
Perfect, sir. Sure. So can I just put this question to Bharti ma'am once before we take the last question of this panel? Ma'am, for doing an obstetric hysterectomy, do you prefer clamping, cutting, and ligating each clamp, or do you clamp, and cut tight at the end so that the chances of bleeding is a little lesser?
That is depending upon the hemodynamic status of the patient actually. If patient is like in a very severe collapse, so we just, by putting the clamp up to uterine, we feel secure, and then after uterine, then we just put the clamp. We have already put the clamp above also, and then just ligate later on. But if patient is little hemodynamically manageable type of patients, and then we can go by step. So this depends upon the hemodynamic status of the patients, because in obstetric hysterectomy, it hardly takes 15-20 minutes, not more than that.
And another important thing that I've learned from my personal experience, when you're doing obstetric hysterectomy, please try and do a subtotal hysterectomy initially. Then maybe required, you can remove the cervix, but then directly doing a total hysterectomy sometimes becomes a little difficult and sometimes can lead to a lot of bleeding and other complications, etc. So Kiran ma'am, I would just like to put this question to you.
One more thing I would like to add. It is very easy for all of us to say, chalo, let's go ahead with an OH, with an obstetric hysterectomy. But those 5 minutes to take that decision is actually very difficult for any one of us, maybe not the senior people here. But then to take that decision, let's go for an OH now, is a little difficult.
Yes, and the decision of a OH, always remember, is not only our decision, it's a team decision of us plus the patient's relatives also. And especially though video counseling doesn't help or doesn't hold good in the court of law, but then it's always good to have a video counseling in case if the facilities are available. Explain everything to them and then only maybe plan for this obstetric hysterectomy. So Kiran ma'am, I would just like to ask this last question of the panel to you. Bleeding continues from the vault and the pelvic walls after the hysterectomy also. So what next? What do you think should be done for her?
Okay, but before that, Dr. Priyankur, I'll just like to say this is the case. In fact, when the broad ligament hematoma, whenever it drains, most of the time it happens, you are not able to find the real bleeder because it has retracted. So these are the cases where the internal iliac artery ligation is more helpful, because you will not be able to find where the bleeder has gone. The evacuation has been done. Okay. And that is the time when my co-panelist was saying applying the clamp on that side becomes very difficult. So here the chances of controlling the bleeding are better with the internal iliac artery ligation.
Can I just interrupt you once, ma'am? Do you or any of the experts present here today have any experience of using the abdominal clamp? Dr. Piley has invented an abdominal clamp, which he claims works very well. Do any of you have an experience with that?
No, I have seen video of his, but we don't have that clamp, number one. and that aortic clamp which is there, but I don't know. I mean, it looks good, but we don't have, and I'm not very sure that we will be able to use it. But it's wonderful. He says as far as experience.
Probably we'll skip a couple of heartbeats when we're applying the clamp on the aorta.
Yeah. So very. I mean,
what's going to happen?
And the next thing, if the bleeding is not controlled, oozing everywhere, then one thing you can do the packing. Pressure also helps a lot into this. One more thing, by the time you send, ask your assistant to send the blood also, because if she has lost blood, the hemoperitoneum was there, so the coagulation factors must have been consumed. So this could also be a factor which has to be corrected by giving fresh frozen plasma and the blood components, so it can help in controlling the bleeding. I mean, at that time, we are desperate, you have to do everything. So the packing has to be done. And if you have a facility, at least we don't have in our medical college, of embolization that can be thought of. I mean, that is one. But I don't know how many institutes do have this facility. What we do is packing and correction of the blood coagulation factors. The internal ileac we do. So that is what works very well. Putting a drain and maintaining the hydration and the IV fluids and vasopressor. Usually, if you are able to replace the blood that you have lost, most of the time it works. Unless and until we have delayed and the patient has gone into irreversible.
Perfect. So basically the things that I would say, probably just to sum up what ma'am has said, probably all our experts have rather said that first of all, call for an assistant help who will assist you, probably a colleague of your stature. Okay, before we sum up, Dinesh sir wants to say something. Sir, your comments?
One thing you must always remember, as we must be giving blood to her. So wrong or mismatched blood transfusion is also one of the cause. So we should always keep in mind, because bleeding from the stitch line or other side is the first sign of mismatched blood transfusion.
Yeah,
so we check blood transfusion.
Hurry, but basically first thing at a time, check your blood bag once it comes, and then you then only transfuse it. And also have a able assistants who will be there with you. First thing is, of course, in case whichever way you find the hemodynamic stability of the patient. And another important thing before we finish this, I would like to mention over here, as ma'am has mentioned about the coagulation profile is something that we can look at, but coagulation profile we need to realize takes some time to come. So instead of that, we can do something called the ROTEM, which has come up nowadays, the elastography that has come in, and that exactly sort of tells us how much units of FFP, how much units of PRBCs, how much unit of platelets that might be required for the patient. And that takes only 20 minutes of time for the report to come, and we can, in the meantime, cross-match the bloods that might be transfused for this patient. So one person can keep doing that when you're operating, hysterectomy for doing it. Ureter, please do keep it in mind. Bladder, a little pushed away so that, once you're done with the subtotal, just stay away from the bladder. Just keep that headache of whether I'm taking the stitch in the bladder or something away from it. Do a subtotal hysterectomy that sort of settles the matter over there for you. Ureter, a little away. Of course, you will not, if you're doing a subtotal, the chances of you taking the ureter is very, very minimal, I would say. And then internal arterial ligation definitely does help. Now, as ma'am has said, abdominal packing, that is something that can definitely be done. But again, that is probably one of the last resorts that we think of when we are doing a case of obstetric hysterectomy. And also angiographic embolization, as ma'am has also mentioned this, that less likely, because the thing is, angiographic embolization when a patient is thoroughly bleeding might be in a state of DIC is not something that we can think of. It could be something in a case of a placenta previa or accreta, which we might have put it from before, put in our catheter there, and then maybe put in the emboli right at the end. So ma'am, here Dr. Bharti Joshi ma'am, from the PGI Institute, ma'am, any last comments, anything that you would like to say would help our patients in this sort of a scenario?
Angiographic embolization, yes, we can go where we feel that there is a generalized ooze from the vault, or later on you have put a drain and you are very sure that you have secured all the vessels and you are feeling that something is coming in the drain. It is 100 to 200 ml per hour. In that case, actually, one thing should be done. Either you go for internal iliac ligation at the time you are seeing a bleeding around the vault, or if there is a bleeding later on, then you can go for the angiographic embolization. Two things cannot be done simultaneously. after doing that internal iliac ligation, it is very difficult to go for embolization because they are not able to feed those vessels. So it is very important we have to choose at least one modality, whatever it is there. And patients' hemodynamics are one of the standards. They decide which modality you can choose at that time and what is the institutional facilities you have all around. So angiographic embolization, yes, postpartum hysterectomy is many times we have to do. Many times in placenta accreta patients, we put a drain. At the time of closure, we are very sure, but then later on we see in drain something is coming out, which is not reassuring. In that case, most of the time we have done angiographic internal embolizations. So one thing has done, either a ligation or either for the embolization, because otherwise technically it becomes difficult for the radiologist.
It will not be possible. In case we have ligated the internal iliac, then it becomes quite difficult for us to pass the.
Yes. Yes.
So again, the thing is, I usually go to a lot of periphery setups, and I firmly believe that putting in a drain is something which somehow prevents us from skipping that beat, because we know that what exactly is happening intra-abdominally or intraperitoneally, especially when you're not able to see the post-op of the patient on a regular basis, probably. So that is something that we need to keep in mind. Now we come to this end of this panel, and I hope that it has given some take-home messages to everyone. I would just like to, Kunika ma'am has raised her hand, so I would take-home messages from our experts over here, starting with Dr. Kunika, because she has already raised her hand. So first comments from you, Dr. Kunika. What would be your take-home message for our viewers present today?
Actually, it was wrong. Okay, I just like to say that we should be very careful in selecting the patient, number one. Number two, monitoring them post-operatively. And then if required, we should intervene as early as possible. And if we feel this thing can't be done at our place, then early referral is the best strategy.
Perfect. The most important line from this, I would say, proper monitoring and referral of the patient at a very early time, which will help us in preventing complication for the patient. Dr. Mini, can I take your comments next, please?
So from my side, it would be like proper counseling of the patient with anticipation of the problems which we can land up in such and such patient, taking it like as the case was the previous LSCS with unengaged head. We need to revise our basics again and again, so that whenever we are doing it on the patient, we know what all can we complicate, what all can we anticipate. Unless we anticipate, we are bound to miss the complications.
Perfect, ma'am. Sure. So anticipate the complications and take consent accordingly, and then go ahead with the treatment. This is what she says. Dinesh sir, can I next come to you for your take-home message, please?
Yeah, it's practicing obstetrics, as madam already mentioned. It's always a teamwork, and so in teamwork, it starts from the basic healthcare staff who are with the patient all the time. There are 10 staffs and the 10 attendants there with them. So they should be well trained to identify any problems are there or not, arising any problem. I said that they alarm you at the earliest possible before it's too late. So well trained staffs is very important in our day-to-day obstetric practice.
Wonderful.
So and there should be a good teamwork, your anesthetist, your surgeon, and all the OT staff should be well trained, and they should be very good and cool-minded. Otherwise, even in the middle of the obstetric hysterectomy you are doing, and somebody is howling that do it quickly, patient is sinking, then you will not be able to probably give your best. So it's a good teamwork and good rapport with everybody, and good support is most important thing in day-to-day practice today.
Perfect, sir. Perfect. Well said. So basically, a good teamwork where every team member will matter, be it right from the staff nurse, the junior most staff nurse, to the senior most person. And for me, I firmly believe when I've landed up with a complication, a cool head on the other side of the table, that is the anesthetist side, really helps us. With a lot of support from them, it definitely does help us. So Ami ma'am, can I next ask for your take-home message for everyone?
Yeah, sure. So don't get ashamed of calling help. Maybe that person can be of your junior, but depending upon the situation, the case, his or her expertise can be of help to save the patient. So don't feel ashamed of any complication. Just identify it at right time and take help of right person. Then liberal but rational use of blood products. One should not forget about DIC while taking care of bleeders. Always keep that thing in mind. Keep a check on it, whether you or your assistant and have a rational but liberal use of blood products that may help you saving your patients in time.
Yes. So in today's day, especially with the advent of ROTEM, I think it's so very important and so very nice to give the number of blood products you require, sort of a thing. You get an estimate of how much to prepare and then transfusing the patient accordingly. Well said, ma'am. Bharti Joshi, ma'am, your last comments for the take-home message for everyone.
Yes, I think the two important things is first is regular drills, and second thing is identification of peripartum red flags. Actually, if you look at any kind of postpartum complications, you will find that these patients have some kind of risk factors, and whenever you try to induce or whenever you try to go for a cesarean, you will able to identify some kind of factors that can lead to retained placenta, that can lead to PPH, that can lead to pulmonary thromboembolism, or they may have an underlying cardiac disease. So that is a very important topic known as peripartum red flags identification that will save most of the postpartum complications. And another important thing is doing regular drills to save these patients. Mimicking these situations will definitely help us in optimizing outcomes in these patients.
Sure, ma'am. Well said. Routine drills, maybe even code blue drills in most of the medical colleges nowadays that we have also definitely does help us in managing such complications. So thank you, ma'am, for that. And last, I would like to come to Dr. Kiran Pandey, ma'am, with her comments, take-home messages for everyone today.
Almost all the panelists have given beautiful messages, and the very practical groundwork has been done, starting from the small home, the nursing home centers to the medical college. Now being in medical college, the new concept with all this, to reduce the maternal mortalities for these critical cares, the concept of critical care specialist is coming up. Like, so everywhere now, the government of India has wants to establish the HDUs and obstetric ICUs. So what the time has come, if we have the facilities, so we should be more tuned to the critical care management. We have to identify the patients of low risk, moderate risk, high risk, divide as already flags have been discussed, and on the basis of that decision we have to keep these patients under monitoring, and all the time these facilities we should try in our centers. We should refer these patients, like referral, Dr. Kunika was talking, so referral to those centers where HDUs or obstetric ICUs are available, because they are very important to save these women. And that knowledge of the physiology, because most of the time the physiology of the pregnancy masks the early complications. So that is the thing which we have to understand. When the warning signals come, they do get masked by the physiological changes, and one is not very sure. And that early identification is the most important thing. Perfect. So that knowledge has to be kept into mind and work according to it.
Perfect. So it's wonderful that at the end of this panel, all of us have come to the same page. The take-home messages that I wanted to tell over here, all of them have been mentioned by the experts today. So that basically brings us to the end of this panel on a happy note, that we will work together, work with each other, work with a team, which will, I'm so sorry for that, which will help us in caring for our patients better, in bringing out the best in us for better patient care and better women's care. We know that International Women's Day is coming up. So wishing you all the women of India and all the doctors present here a very happy International Women's Day. Take care of yourself, and thank you so much for giving us this opportunity to be with all of you and for this wonderful panel. I would like to thank everyone on behalf of Dr. Vidhu Modgil and all the expert panelists today for being with us. In spite of we being 1 hour late, thank you so much for being with us, and thank you for bearing with us.
Thank you, Dr. Priyankur. You have conducted the panel very beautifully. Dealt with all the practical day-to-day scenarios. That was the most important for everybody to manage. And I'm actually extremely thankful to all the organizers, Mini, and all the societies who have given us this opportunity to be into this. And also would like to have your blessings for the forthcoming elections, as I am contesting for Medical Education Committee Chairperson. So we'll request everyone to give their blessings and vote and support also. Thank you very much.
Before we end, can I just, Dr. Mini, can I just get a couple of minutes from you? And I request, I see Dr. MC Patel sir is still with us. So, Patel sir, can I just request you, in case if you can hear us, can I just request you to give your medical legal views on this sudden obstetric, critical care in obstetrics, sir?
Pardon?
If I can just ask for your views, medical legal views in the case of critical care in obstetrics, sir. Like medical legal aspects that can come up in a case of critical care in obstetrics, how critical care, there's a complication, how do we go about? Maybe in a couple of minutes, if you can just tell us a little bit.
So in any mishap happened in our obstetric practice, in spite of our due care and caution, many times litigation may happen. In this type of situation, usually in court of law, we have to answer certain questions. And first questions comes, was it preventable? Whether it is complication of PPH or whether it is sudden collapse or anything. So usually we cannot say, no, it was not preventable. So if it was preventable, then what did you do to prevent it? So you have nicely discussed the case of third stage of labor management to prevent PPH. So that way, if we have taken utmost care to prevent any complication, then it becomes a good defense. One more question comes. In spite of your care and caution, if you couldn't prevent the complication, then did you diagnose that complication in time? If you have diagnosed that complication in time, then did you manage that complication way in which any prudent gynecologist would have managed that complication in a given situation? And as per standard textbooks, norms, medical norms, or in practice in prevailing in nearby medical college, or practice prevailing in peer group, all these are taken into consideration in court of law as far as this type of litigations are concerned. But how you will prove all this with good and proper record keeping? So whatever you do in any given situation, any given case, please enter everything in the record. If you have involved your professional colleague to help you out in certain situation, then involve their note also, seen by so and so, his or her findings, investigations advice, treatment advice, and all this should be carried out and it should be reflected in your nursing chart also. So if you do like this, then in any mishap, there is nothing to worry, because negligence, to prove negligence, it's very difficult for anybody against doctor, because any complication is not negligence per se. Complication may occur at any time, at any place, by anybody. But if we can prove that we took utmost care to take to save life of patient in given situation, and if we can prove by our proper record keeping, then we are out of problem. Nothing to worry.
So we're keeping your card and your phone number in our mobile.
Yes.
That's also very important. Namaste.
Yes. Well, let us hope Jarut na pade. But if at all it happens, I am always there to assist you.
Yes, sir.
Yes.
And so you have taught us one more thing, that every like consent part is very important.
Yes.
Do only that which has been, for which consent has been taken. Do not go beyond that in any case.
Yes. And just you have mentioned about consent, let me share information. You visit Foxy website and go to uniform consent. We 3 medical legal experts have prepared almost 30 consent for different procedure and different surgery. Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and Dr. MC Patel from Ahmedabad. We have prepared all those consent. And we have divided those consent into 2 parts. One part is part A, that is information, and second part is undertaking. So we have taken a page of famous case of Samira Kohli versus Prabha Manchanda, which was decided in Supreme Court in 2008. And in that particular case, Supreme Court has come up with what could be the criteria for any consent to be valid. So considering that case, at the time of preparing all those consent, we have prepared all this consent, and we had an ample discussion with Maharashtra Law Society, 2 retired High Court judges, 1 sitting High Court judge, 1 senior advocate from Supreme Court, one senior chairperson in National Commission. So we had a discussion for one word or one line for hours together, and then only we have come up with this uniform consent. And in that consent, we have clarified each and every aspect as far as any given situation is concerned, whether it is cesarean section, whether it is hysterectomy, whether it is os tightening, whether it is hysterosalpingography, whether it is medical termination of pregnancy, either by medical method or by surgical method. And one more thing, whenever you visit that consent, uniform consent on FOXI's website, if at all any suggestion, any correction, we are open to discuss with you, because this consent, we never claim that it is exhaustive consent. It is suggestive consent. And if any suggestion or any correction is there, we will have a good discussion and we will come up with correction if at all it is needed. So as far as consent part is concerned, we have put it on FOXI website.
Thank you so much, sir. And I would just like to inform from Vashish from the Corona Remedy side, just put up a message saying that we had almost 375 plus delegates today, which I think is a wonderful number, considering it's in a weekday and we have so many programs also running simultaneously. So thank you so much everyone for attending, and I'd like to hand over to Dr. Mini Bedi ma'am to kindly forward and maybe close the session.
Well, it was a wonderful brainstorming session, sir. Wonderful bonanza. But then just a few words, I would like to take the privilege of thanking each and every one of these esteemed faculty members who are present here for such a wonderful, meaningful learning session. I can say about myself, learned a lot from all these things. And I would also like to thank Corona Remedies for arranging this webinar and putting us all together into this. Thank you so much.
Thank you. Thank you, everyone. Please take care. Thank you.
Thank you so much.
Thank you.